Good morning, everyone. I think it's almost 10 o'clock, so we'll begin. Uh, welcome. Welcome to this wonderful Shaw House, a stunning building. And I would like to start with some introductions, if I may. And this is the first meeting for Victoria Otley-Groom. We're happy to welcome to the ICB board. Welcome, Victoria. She's a digital and information officer. And I'd like to formally thank Ross, who since left, for all of the work that he's done in his interim capacity. But welcome, Victoria. Just to let delegates know that Raj Bamba's secondment has ended. She was the CPO and she's returned to NHS England. And we're very pleased to confirm that Caroline Corrigan, who's the Frimley ICB Chief People Officer, actually, is going to provide support to us on an interim basis. So we're very pleased to welcome a very experienced CPO into our midst. A couple of apologies today. We've got apologies from Tim Nolan and from Aidan Rave, who are both abroad at the moment. And Steve McManus, our trust partner member, has a CQC maternity inspection. So he's away this morning, but will be with us this afternoon. So just in terms of reminding everyone about the development of our agenda, and obviously this is a constant learning process. So our resident story will continue to be included, and we'll do that to make sure we start the meeting remembering what we're here to do, so that we anchor everything we do in the outcomes for our residents. And the stories will be selected and chosen for their role in supporting our providers and to help us drive integration and to help us, I suppose, address issues raised and making sure that we're contributed to the learning that we need to have. This meeting, as we discussed before, will be the first one to include a place update, so a geographical county update. And very welcome to Sarah Webster, who is going to present that, who is our place director working within the wider partnership. And place, just as a reminder, because we often get asked, the definition of the word place refers to the individual, the pre-CCG geographies of our area, just to be very clear. And we, as you know, we also rotate the venue of the meeting to make sure we cover all of our geography, and we'll continue to do this. And today we're delighted to be hosted by West Berkshire Council, Newbury, for the first time actually in this wonderful building. So just a bit of housekeeping, please. This is a reminder, this is a meeting in public, not a public meeting. So the event is being live streamed, and for those tuned in virtually, the tech is set up so that you can observe only. So please remember to unmute your mic before speaking, please, board members. And we have a camera with a fixed focal length. So what that means is we can't zoom in, unfortunately. So please could I ask all of the board members to remember to introduce themselves so that people following can hear and understand who is talking before each contribution. And that's just making it easier for those at home to follow the conversation. It's easy to forget, so I'll try and remind you as we go through. Moving on to the meeting then, please can I have a sense of whether the minutes from the last meeting have been approved? These are presented in a streamlined format, as you can see, so we've tried to capture all of the key information in a way that's easier for you to follow. The meetings are recorded and the full board papers are uploaded for those wanting any detail. So no new actions from September's board to note, but the accompanying actions log is included as a nil return. So can I just have a show of hands, please, for approval of the minutes? Great, thank you. Declarations of interest. It's quite complicated for us, as you know. So the current register is attached for information. You can see everyone's interests. Please declare if there are any interest in the agenda items, but where these are known, we've already been included on the front sheet. So we've outlined where and how these interests will be managed. So the nature of our board, we're a unitary board with partner members, means that there are inherent interests because of the organisations and I suppose the lead that they take in some of the subject matter. So if we look at where there is an interest, item 7, obviously the Chief Executive Director's report. Item 8, addressing the significant financial challenges. Item 9, the Berkshire West Place update. Item 10, our approach to 2024-25 strategic planning. Item 11, the Primary Care Access and Recovery Plan. There's an update there. Item 12, the Digital and Data Progress. Item 13, Performance and Quality Report. And item 14, the Finance Report, month 8. So just for noting there. So items 8 and 10 are for approval. So I'll need your approval today for this. And the others are for information, assurance, and discussion, not for decision. So the level of conflict is manageable, and as the perspective of all members is vitally important. All may participate in discussion and decision on this occasion. To note, there was a typo actually in the previously published Register of Interests. Margaret Batty's board member relevant interest was listed as Age International, and it was actually listed as APE International, and it should have been listed as Age International. So apologies for that if people were trying to understand what APE International stood for, but we've amended that in our records, and it'll be correctly reflected in the published interests going forward. So we've had some questions from the public, and this is welcome always, and we encourage this. But this is a meeting in public and not a public meeting. So where possible, presenters will answer the questions during the relevant agenda items, and we'll bring those up at the time. So we received 5 questions actually altogether, and published by our deadline. So the questions relate to items 5 and 6 and 7. So one question that came in was not related at all in any way to today's agenda. So what we'll do is provide written answers for those. And the question, and we commit to providing the published written answers within 20 working days of this board meeting. So the one question that we're not going to allude to today is about treatment, but we will write a full and proper written response, which will be published. So moving on, I'm delighted to ask Rachel to present our residents' stories, and just if the board could take note, and to note the impact that personalised care that we'll hear about today has in the videos. And I suppose just to say that if members of the public can't follow the resident story, there are links attached to our published papers, so all can see. So I'm going to ask Nick and Catherine just to move to the side because the screen is here. So over to you, Rachel. Thank you.
Thank you, Chair. So my name's Rachel Corser. I'm Chief Nursing Officer here at NHS Bob ICB, and I'm delighted to present 2 resident stories that are aligned to what we have committed to within both the Joint Forward Plan, but what's also integral within the NHS long-term plan around the personalisation of care. I was fortunate enough a few weeks ago to spend some time with our very own teams that are delivering and supporting personalised care within the primary care footprint, and seeing the impact firsthand of social prescribing on our local community in empowering our populations to take responsibility for their own health. And I think what we're here this morning is examples of where this is really impacting positively on the lives of our population. And we've related these stories particularly to the local population of Newbury and within the Berkshire West footprint, as we do when we bring these patient stories through to our board. I'll leave it there. Thank you, Chair.
that evening, I started to experience really intrusive thoughts, very worrying thoughts, probably on the border of psychosis, that I wanted to harm the baby. I couldn't hold the baby because every time I did, the thoughts would get worse. At some points, if I held the baby, I was having thoughts to throw him on the floor, drown him, throw him out the window, hit him with a hard object. It was awful, to the point that I couldn't bond with him. I didn't want to care for him anymore. I was seen quite soon after the birth, but there I didn't find it very helpful at all. And I did find they were touching on previous bouts of mental health episodes I had had, which worried me. So I was afraid to speak about what I'd been thinking, in case they would take the baby away and even lock me up. It took about 3 or 4 months for me to actually speak about it. And in this time, I'd actually been discharged from mental health services because I'd pretended I was okay because of fear of what might happen. Pregnancy was so much more smooth sailing. Afterwards, I didn't suffer with any mental health like I did before. And I believe it's all because I had personalised care. I was allowed to speak to someone and discuss options. I was also, given suggestions, but I wasn't forced to do anything. And I was allowed to, speak with someone about what choices I had, and we worked it out together. I think it was life-saving care that I've had recently. At my very lowest was when I was very serious about wanting to not be here anymore, so very suicidal. And it was my sister that really saved me, because she came straight round. I had just like a big handful of pills I didn't take, but that I was going to take. And I know that probably wouldn't have done it anything like final, but I didn't do that. And I was also thinking about falling from my loft. I saw a different consultant every time, which meant I had to say my whole story again, because they didn't seem to read the notes, which was quite distressing to have to start again every time. They would all suggest different treatments, different medications. I'd often find myself feeling very despondent and not feeling like they really knew what was going on with me. So it was hard to trust. I've had recently very good care, which I would say is very personalised care. It was the same consultant that seen me, the same staff that treated me. They work together as a team, so they have discussions so that they know what's happening with us, so that when I see the consultant, she can be very up to date with what's happening. And she would talk to me about the different treatments so that we could weigh the ups and downs of different medications and what would be suitable. And yeah, I really trust her, I think, and she really knows me.
Rachel, thank you for organising those stories. And I wonder if there's a question from a member of the public about personalised care. Have you seen that? And I wonder if you just sort of help us with the point of the range of stories that we will bring. But personalised care can mean a lot of things in different settings. So perhaps you could give a sense of what that means and how to reflect that we care for these people in different ways.
Thank you, Chair. So yeah, and thank you to the member of the public for the question. And I think we often try and frame our story, bearing in mind again that this is the second time that we've done that through the board in public. And it's important to us that we relate it to something that's close to the community in which we are attending. And the reason we chose these two personalised care stories are because they relate to residents from the local community, and therefore the impact that they've had on receipt of their personalised care, but also, as you saw at the end, how they are now contributing back into volunteering to support those personalised care, the journey around our development of the personalised care agenda. And as we've heard, they're two very different stories, both relating to their own journey through personalised care and the impact it's had on them. And personalised care can be wide and varied, from social prescribing through to people being involved in much more extensive and comprehensive care and treatment going forward.
Thank you. And there's just, before I pass over to Nick, there's just another question that I'd like to share. So we've had a question from Councillor Stefan Garisiak from Henley-on-Thames, and he's asking, the board meeting is a meeting in public and not a public meeting. So he's asking why there's no public participation session at the ICB meetings. And as I've explained, so we welcome questions submitted in advance. And when related to our agenda items, as we explained, we'll pick up that question there. And of course, there are other mechanisms for our public and other stakeholders to engage with us. And Nick will mention some of the engagement sessions we're doing. But one of our ambitions is actually to look at ways of further engaging with our communities. So what we'll be doing is speaking to our local authorities to help us do that. And we recognise that as an area of opportunity to be done in that space, but we welcome any suggestion as to how effectively and efficiently and fairly. Thank you. So let me pass over to Nick Broughton, our Chief Executive, who's going to give us an overview of performance. And I think if you just note Nick's update, and also specifically, he'll pick up the point on the NHS Sexual Safety Charter. You'll see that we've signed up to that, and I hope you're in agreement and happy with that. And I think the thing to pick up, and hopefully you'll pick up from Nick's presentation, is the fact that we are delving deeper into our stakeholders and our communities with full engagement. One of the roles of the ICB is to convene and to create the environment for integration and collaboration, which I'm pleased to say we're doing. And I think the primary care strategy engagement will be proof of that as well. So over to Nick.
Sim, thank you for that, and good morning, everyone. It's great to be here in this fantastic building. Before I go on to my report, I just wanted to reflect on what we've just heard in terms of the resident story, particularly Nina's story and the focus on postnatal mental health problems, which are significant, they're very common, can have tragic consequences, and it was great that Nina's experience was ultimately a good one. What it did highlight to me, though, is that we do not have a mother and baby unit in our system. The nearest mother and baby unit is in Winchester. And when we think about personalised care, we do need to think about ensuring that we have the services that our residents need as close to them as possible. It's certainly something which has been at the forefront of my mind since working in our system, that we have mothers living in Oxfordshire, living in Buckinghamshire, who will be admitted to a unit many, many miles away from their family and friends. So moving forward, when we think about our long-term strategy, when we think about the services we need to be delivering within our system, I would ask that we make sure that we consider the requirement for a mother and baby unit, possibly with colleagues in Frimley or whatever, but there's a very few of these units around, and I think there's a gap in our service provision. Moving on to my report, I'm not going to go through it line by line, which will come as a relief to you all. I'm going to say a few words about a couple of items, and then I'm going to invite Rachel, our chief nurse, to say something about the sexual safety charter and indeed the recent SEND inspection and what we're doing in response to that. And I also invite Rachel, our chief medical officer, to say a few words regarding the work that's in train in relation to developing our primary care strategy, particularly the engagement that's planned in relation to that. The report, I think, highlights the two things that we are trying to do. One is to obviously deliver services today, so to balance the demands that we're facing in terms of the money, in terms of operational requirements, etc. But at the same time, to think about the longer term future and how we can ensure that our system is placed on a more sustainable and resilient footing in the medium to long term. I begin in the report by highlighting the challenges associated with industrial action. You'll see the numbers in relation to the impact on outpatient appointments, elective procedures, etc. There's also been a significant financial impact. As we sit here today, we are awaiting the outcome of the latest ballot by the British Medical Association, which will end on the 26th of December. And obviously we are hopeful that will not result in further industrial action given the impact that that's likely to have. In light of the significant impact to date, however, we received a letter, as did all systems, from NHS England on the 8th of November, highlighting that we needed to revise our operational and financial plans for the remainder of this financial year. There's a very tight turnaround, about 2 weeks to do this. As you'd expect, this is not a small undertaking, and a lot of work has been ongoing. I'm very grateful for the support that we have received from colleagues in our provider trusts across the system. We are not in a position today to present a final version of the revised plan for sign-off from the board. You'll see that as down as agenda item 8 on today's agenda. So what I would ask is that the board delegates authority for sign-off to the chairman, to Matthew, our chief finance officer, and myself. There are a lot of moving parts still, so hopefully we'll be able to do it within the next 24 hours. Ask for that delegated authority to be granted. Thank you. Moving on. One of the key roles of our integrated care board is the system leadership, the system convening role. And I'm very pleased to say I think we are becoming increasingly active in that space. And there have been a number of important events since the board last met, when we brought together various key stakeholders to think about our strategy, to think about how we can transform how we deliver services. Rachel will come on to where we are with the primary care strategy development, but I just wanted to mention the leadership forum we held on the 30th of October. A number of people in the room were present. I was very grateful that there was strong representation from our local authority partners, both in terms of leaders and chief executives. I think it was a very useful event, not least because it challenged our thinking. We had the benefit of someone who's worked globally, who's got experience of working in integrated care systems overseas. And it certainly, I think, highlighted to us the art of the possible in terms of what we might be able to achieve going forward. And also, I think, helped stimulate our thinking in relation to planning for the next financial year, beginning in April 2024. And that is a real opportunity for us to start to reset how we deliver services, and particularly how we can enhance the offer that we provide in our community and in primary care. There are huge challenges that we are facing in the National Health Service at the present time. And in light of those challenges, NHS England commissioned a piece of work earlier this year to look at the approach that's being taken towards developing a continuous improvement culture and methodology across NHS organisations. This programme is now called NHS Impact, Improving Care Together. There is a National Improvement Board which has been established, looking at how we can disseminate best practice, how we can support organisations to develop a continuous improvement capability. And I'm very pleased to say that I've been asked to sit on that board and to represent the South East Integrated Care Boards. Within our system, we already have a number of organisations that are well advanced in terms of continuous improvement, particularly thinking where we are today. Berkshire Healthcare, Amino, as Chief Medical Officer, will be able to speak far more knowledgeably than I can, but an organisation that has developed quality improvement and embedded it for many years now. It is a golden thread that runs through that organisation. And when you visit Berkshire Healthcare, wherever you go, you can physically see that quality improvement is having a tangible effect on how clinicians from all professions deliver care and address some of the day-to-day challenges they're having. So we're in a good position. What we want to do is harness that capacity, and with that in mind, we had a quality improvement festival earlier this month with representation from all provider organisations, and I'd like to think, compared to some systems, we are slightly ahead of the curve in relation to QI. We as an organisation, however, need to think about the role that we play in driving forward continuous improvement in our system. We've completed a self-report as part of the NHS Impact programme, but I would suggest that this board needs to receive an update at some point in the not too distant future regarding our findings following completing that self-assessment and the next steps we intend to take, not least in terms of how we develop a quality improvement culture within the ICB as a standalone organisation. So, Chairman, if possible, I would like to have that as an action, and hopefully we could be able to bring something to the next board meeting. Okay, and I think that's all I want to say by way of introduction to my report. I'm now going to hand over to Rachel just to say a few words regarding the Sexual Safety Charter and also matters SEND.
Thank you. Thank you, Nick. So you'll see in the Chief Exec's report that the ICB has signed up to the NHS Sexual Safety Charter. We are now one of nearly 200 NHS organisations that have done this. That's just the beginning, of course, because there's a whole piece of work that we need to do in conjunction with Caroline, the Interim Chief People Officer, to try and develop that culture within our ICB, but also working with our partners across the ICS who've also signed up for the Sexual Safety Charter to make sure we're supporting them in their ambition through that charter as well. So we'll continue to report and feed that through People Committee. And then SEND, so I've informed board at the September meeting that we just received the final report into the inspection that took place earlier in the summer in Oxfordshire County Council, a combined inspection with our colleagues from the CQC and Ofsted, looking at the special educational needs and disabilities offer within Oxfordshire. We were really disappointed to be judged as having systemic and widespread failings along that inspection framework. But as reported last time, we have worked collaboratively with our partners across the health, education and local authority to respond rapidly to the requirements that have been set out within the actions that have been set out to us. It does include subsequently a formal improvement notice that's been sanctioned to the Oxfordshire County Council. And again, we're supporting them through that process, working in partnership with them. As you'll see in the Chief Exec reports, we've implemented an internal ICB improvement board that's been chaired by the Chief Executive to support us as the ICB in ensuring that we are delivering on the components that we need to deliver against those SEND frameworks, both in terms of Oxfordshire response, but also in support for Buckinghamshire and the 3 local authorities down here in the Berkshire West footprint. I think it's fair to say that the amount of time and effort that we are having to spend in supporting this agenda is enormous, and our teams are really proud of the efforts that they are making in trying to turn this around and moving it forward. And I look forward to coming back in due course to board and sharing some of the successes that we've been making collectively with our partners and the progress that we've been making against each of those areas. Thank you, Chair.
Thank you, Nick. Rachel Deco, Chief Medical Officer for the ICB. So I'll give a kind of brief framing. I'll also take one of the questions that's come from the public, and then I'll hand over to Sarah Adair as Acting Director of Comms and Engagement to take the further question from the public regarding the comms engagement piece. So the ICB is currently developing a strategy for the future of primary care, which when we talk about it at system level includes general practice, community pharmacy, optometry and dentistry across the whole footprint. Now, clearly, this is a very complicated and complex piece of work with multiple interested parties and stakeholders, as reflected by nearly 140 people attending the workshop in October, from patient participation groups, voluntary sector, public health, and key partners. And we recognise that it's a key enabler to delivering the ambitions of our joint forward plan. But more importantly, it's pivotal to our population and our workforce to deliver a sustainable model of care that gives residents improved access, experience, and ultimately better outcomes. So the broad aims of the strategy are to build a shared understanding of the current state of primary and community services and to present that case for change. And we're just completing that factual accuracy piece of that particular piece of work. To build a consensus on the future vision for primary care and its integration. And again, that's the phase we're moving into, starting with those discussions in the workshop, but now really keen to move into the engagement phase where we're hearing from our residents and population. We then need to design the way we deliver this care, i.e. the operating model, and look at tools such as digital to support, test the practical application of any new model, and capture learning and build capability to roll out the final strategy. And then on that note, there was a question that came in from Sean Cask, the chair of the local optical committee. The question was, with better communication between all primary care, including GPs, the board could be encouraging local commissioning to include the pod, so that's the pharmacy, optometry and dental work of the population. In optometry, for example, there's a workforce which is capable of and willing to help reduce the pressure in hospitals and GP practices. This would mean better access to eye health advice and care. What plans does the ICB have to commit to commissioning differently to before to include pharmacy, optometry and dentistry? And just to take that question, if I may. So first of all, to say that the ICB hugely values the services provided by community pharmacy, optometry and dentistry, and we are absolutely looking to commission in a different way. So in June this year, we introduced a flexible commissioning scheme for patients who've struggled to get a dentist, particularly those patients in our more vulnerable populations. And we now have community optometrists that are able to make direct referrals to secondary care services. Our next step is to pilot optometrists undertaking some diagnostic steps pre a hospital appointment to ensure better triage so that the patient is directed to the right place with the aim of freeing up capacity in secondary care and making it a smoother process for the patient. I'll hand over, to Sarah Adair in terms of the comms and engagement piece.
Thank you, Rachel. Sarah Adair, Director of Comms and Engagement. So we launched the public engagement on Friday last week as part of the strategy development work. At this initial stage of engagement, we're asking the public to share their views, insights and experiences of primary care. This will be followed mid-December, where we would like to publish the draft strategy for comment and suggestions from our public and partners. The engagement will run till the end of January 2024. We will be working with the joint Bob Hosk, so we'll be presenting the strategy and some of our engagement on the 24th of January. We'll be hosting some events. Health Watch will be hosting some events with us. We'll run some ICB events, and we'll also be running focus groups across the engagement period to try and target some of more hard to reach groups to seek their views. So we did have a question from a member of the public and also with some very helpful feedback that he gave about the engagement. The question was, will stakeholders and the public have an opportunity to comment on the strategy? And if so, how and when? I think I've answered the question there. We will be publishing the strategy mid-December, and there will be ample opportunity for people to give that feedback. We have made some changes to our engagement website, which is hosting the engagement and documents and information relating to the strategy on the back of the feedback from the member of public. So thank you very much for that.
Thank you, Sarah. The engagement platform is accessed via.
So you can get to it through our corporate ICB website, or it is Your Voice in Buckinghamshire, Oxfordshire and Berkshire West. But we're doing lots of social media to raise awareness. We've done a press release around the engagement, and we'll continue that work throughout the period of engagement. So that should be made available.
Thank you. And can you define HOSC, please? You mentioned the word HOSC acronym, meaning for the public. Thank
Apologies. That's the Health Overview and Scrutiny Committee.
Thank you very much. May I now take the opportunity to ask for reflections on the resident's story, if there are any, and also any questions for Nick, Rachel, or any observations that this board would like to make. I realise you've listened a lot and there's a lot of information that you've taken in, but I think now is a good opportunity just to get a sense of some feedback. So if I could open that up, if anyone has any questions or reflections. Margaret.
Thank you. And thank you for the various.
Margaret, say who you are.
Margaret Batty, Non-Executive Director. Morning. Yeah, thank you for the various presentations and the videos and the stories. Just one very broad observation is that personalised care sounds to me what used to be old-fashioned care, that we used to have the same GP all through our lives, that we used to see the same person all through a treatment. I mean, I know there's a lot of different dimensions and there's new dimensions, but it just seems like what used to happen when there was more resourcing. But my question to Nick actually is on the Q2 assessment by the regional team, so not paragraph 35 in your report. I just wondered if there were any kind of headlines or concerns or surprises that came through that report, Nick. It took place a couple of weeks ago, so on 6th November. Thank you.
Margaret, thank you for that. By and large, it was a positive experience. I think the regional team went away with the view that we are developing as a system, that the executive team is getting stronger, that system working is becoming more routine, so that they're pleased with the direction of travel. Having said that, obviously they are very aware of the significant operational financial challenges that we face, which have been significantly exacerbated by industrial action. And it's fair to say that meeting preceded the letter asking us to revise our plans. And the reason why we and the other 41 systems have been asked to revise plans is because nationally plans have not been on track. And there is a need to tighten belts and ensure that we can maintain elective performance, emergency care performance, particularly over the winter months. But overall, I think they feel that we are doing reasonably well. Progress is being made in a very difficult climate, which I think is as good as we could have hoped, being frank.
Rachel, thank you.
Thank you. Rachel Sherman, Chief Executive, Buckinghamshire Council. I'm here representing the local councils within this geography. I've got 3 questions. Firstly, on personal budgets, how are we monitoring take-up of personal health budgets? Because the video extracts are compelling in relation to the quality of care, and I think everybody around this table would want to feel that every patient within our geography was receiving that kind of care. So how are we modelling take-up? How do we know that healthcare practitioners understand the kind of model? Really, that's my first question. My second question is in relation to Nick's report and the section on funding. So I noticed the reference to the NHS letter, and I know we're going to come on to talk about some of the financial issues in a moment. It's clear, though, that there is a very clearly focused expectation from NHS England about areas of priority. However, At the same time, we know that we've got some financial challenges, partly but not wholly caused by some of the industrial action. And then we've also got some really big challenges around service improvement. So we've talked about SEND already today, and we've got a special education needs and disabilities issue, I suspect, across all of our patch. So I suppose my question in relation to funding is, how are we clearly articulating what the art of the possible is in relation to all those asks, both from NHS England, but also our local issues and tensions in terms of the services that we need to pay attention to, because we've got a finite amount of resource and a very significant degree of demand. And then thirdly, and finally, on the primary care work, is there a specific discussion for elected members across our geography prior to the 24th of January joint HOSC? Because that feels quite a long way away. And it would be really helpful, in my view, to be able to talk much more openly and directly to elected members about the emerging plan. Thank you.
Right. You want to?
Yes, so if I try and take question 2, in terms of individual care packages, I will ask Rachel, our chief nurse, to deal with that, and then the primary care matter will be Hannah. Okay, so in terms of the finance, obviously we've got a financial update on the agenda today, which I'm sure will touch on this. In relation to the ask from the national team, as stated, there is a lot of work in train. We're not in a position now to present to the board the final version of the revised financial and operational plan for the system, hence the request for authority to be delegated to Sim, myself and Matthew to sign that off in advance of submission. But it's a very challenging environment, Rachel, being frank. The demands on budgets are extensive, and you're right to highlight that it's not just a consequence of industrial action that the finances are so stretched. The various other factors, not least inflation, issues in terms of workforce, and the fact that workforce has increased overall, and in some cases above and beyond what was planned by individual organisations. We also have had challenges in relation to delivering what are termed cost improvement plans within individual organisations. I think if I was going to answer your question at a sort of high level, what I would say is clearly we need to sort out the here and now. We're going to do that in terms of the refresh of the plan. But we need to rapidly start thinking differently about how we deliver services, where we're spending our money. We will always have a case that we don't have sufficient funding. But I think we can be a little smarter with how we actually spend the money we get. And this is where I think investing more in community services, investing more in primary care, focusing far more on prevention, delivering proactive models of care to people, particularly those people with long-term conditions, not only is the right thing clinically, but will be the right thing financially. And then linked to that, we all know that we can do things more efficiently, more effectively. And the quality improvement approach is something that we need to ensure is embedded across certainly all our NHS organisations. We need to learn from the best, because we need to use whatever resources we have as efficiently as we can. And being frank, we don't always do that. I hope that gives you some sense of our thinking, our approach. Matthew will touch on some of the granular detail regarding the money later on this morning, and you will have sight of the refreshed plan as soon as we've got it. So if I look to Rachel now for the individual care packages question.
Thank you, Nick. Thank you, Rachel, for that question. I'm just not looking on my phone, but trying to scroll down to get the current data, and apologies, I haven't been able to find it. So I think it's fair to say around our compliance with allocation of personalised health budgets hasn't been where we've wanted it to be. We have appointed a dedicated programme manager to work with us on delivering that. We're running at about 25% of our trajectory, with a really ambitious commitment to delivering that going forward. I think it's fair to say as well, our colleagues at NHS England have been giving us the support, but also the additional scrutiny of compliance against that trajectory. And in fact, only at the quarterly meeting were we given the same challenge. So it is something that we remain focused on. We are making good progress, But I think with the appointment of a programme manager driving that forward, we'll certainly make the successes that we need.
Sorry. Hannah Iqbal, Chief Strategy and Partnerships Officer. Thank you, Rachel, for your question around the primary care engagement. I think you're right, actually, in acknowledging this gap, and that actually, if we wait to January, we're missing an opportunity. So I'd really welcome working with you and how we land a different kind of conversation with elected members this side of Christmas, so that we can then maximise our January discussion. I think that would take two parts, both in terms of I would like to, with you, think about writing to elected members this week in terms of how they can help engage this more widely and socialise it, but also this side of Christmas, how we have a kind of scoping wider conversation with them ahead of a more formal discussion within the Health Overview and Scrutiny Committee. So I'll pick that up with you offline. Thank you.
Thank you, Hannah. That sounds positive, Rachel, that last bit. So it's just a time issue, I think, but I know you'll help us try and organise that. And I wonder if, George, did you want to comment on the primary care?
I suppose it's worth
yes.
flagging, we do have an integrated care partnership board meeting tomorrow. So that will be hopefully a useful opportunity to.
That's a good point, actually. We can talk about logistics there. Thank you, Nick.
Just if there's anything you want to say. No? No, okay, lovely. In that case, if there are no reflections or questions, we will move on with the agenda, if we might. So we are moving to the Berkshire West update. So I'd like to invite Matthew Tate and Sarah Webster to introduce this item. This is the first time we will have done this. And so people have received the papers. Let's hand over to Matthew.
Morning, so Matthew Tate, Chief Delivery Officer for the ICB. So I'm really just have the pleasure of introducing Sarah to the board today. Delighted that we're doing a focus on each of our local geographies. I think it clearly demonstrates how important those partnerships are at a local level to deliver care, improve care, engage with the population, work with key partners such as local authorities. And Sarah's been doing a great job coordinating that in a complex Berkshire West system. But over to you, Sarah.
Thank you very much, Matthew, and thank you all for having me here, even if in a way I am the guinea pig smoothing the way for my counterparts in Buckinghamshire and Oxfordshire for the next meetings. I'll assume the slides have been read. I'm not going to do a page turner. I did think it was helpful to include the overview of kind of the complexities of our partnership, particularly to highlight that we've got 3 separate unitary authorities within the geographical area that I cover, which brings a different nuance of its own. And I think it's also what's not represented in the slide, and really importantly, is the pharmacy, optometry and dental services. And that's an area that I acknowledge we need to do a bit more on in terms of how we create that local focus on those services, whilst acknowledging that they're also being looked at from a Bob-wide lens. And so how do we get that balance right and make the best use of colleagues' time? And I also included in the slides kind of some of the focus areas that we're looking at on as a partnership. And I just wanted to emphasise that these are some of the areas that we know by coming together as partners, we'll be able to make a difference on. That's not saying that these are the only things that are important in the area. It's kind of, that's where the partnership focus has been, but there's an awful lot of work going on outside of those as well. I did just want to take a moment to hover on the slide around our community wellness outreach model and how we are using the ICB inequalities and prevention funding locally in Berkshire West at the moment, because it's been a fascinating exercise in partnership working to get us to the right outcome and the right model. So a common theme that was coming across in our joint forward plan, in the joint strategic need assessment, in our health and wellbeing strategies, was around the fact that we know that lives are being cut short by cardiovascular disease and cardiovascular events, and that where you live makes it more or less likely to happen. And something needs to be done about this. So all the relevant partners, we got together in a room and said, we've got this funding, we've got an opportunity to do something together. What should we do? And had a really collaborative effort to come together to think about what's already working well in the patch, how we might build on that. And through those conversations, we've developed the community wellness outreach model that I've outlined in the pack to give you an overview of what we're doing. And I suppose at its simplest, it's sort of enhanced health checks and signposting and follow up. that we're taking out into the hearts of our communities where it's slightly different. So we're inviting people to come along, but we also know that's not always the best way to reach people. So we are going to be taking this into community cafes, libraries, and then building on that, can we involve more community pharmacy, knowing that they are hubs in the communities as well, to really take services to the people who need them the most. But that's at its simplest. But what I'm really excited about this, it's also almost a fact-finding mission. So someone who's coming in and they present with high blood pressure, why is that? What are they worried about? What's causing this? And if we look at the themes behind what's causing people to have these conditions now, as a partnership, we can then start to address some of those wider building blocks of health. So it could be housing, it could be we don't have access to the right sort of green space, I don't feel safe in my community. And then that's how we get to the root cause and really start taking prevention seriously as a partnership. So that's something I'm particularly excited about. And also it's scalable. So what we're doing here is creating kind of those roots in that we're going to hope some well-trodden paths into our communities together. So we're doing this in a coordinated way and not kind of coming at it from lots of different angles. But also if more funding or resource or people time is available, then come along as well. Let's piggyback on this. Let's bring in other services as well. So that's something that could make it really sustainable and that I'm really excited about. One of the nuances to reflect, and it's almost a kind of a microcosm of wider system working, is we're really clear that we want sort of consistent offer and consistent outcomes for our residents across the Berkshire West patch. But the delivery vehicle, the way we're taking these health checks and conversations out into the community will vary based on the 3 local authority areas, because we've built up upon what we've already got in place. And I will admit that put me in, made me step out of my comfort zone initially, working through that and not having one consistent approach. But actually, it's really testing that theory of kind of really localized services, building on what's already there. And it gives us the chance to review and compare and contrast the different vehicles that we're taking out into the communities and take the best out of it once the pilot period ends. So that's really, I'll there's more in the slides. You may well have questions and I want to save time for that, but I just wanted to kind of hammer home that point around when we come together and when we really think about prevention, it could be really fundamentally kind of improving the wider health and well-being of our populations. And I just really wanted to kind of spotlight on that for today.
Thank you, Sarah, and thank you for the very comprehensive slides. And I've noticed you've put sort of take-home messages for the ICB board, and maybe that's a good place for us to sort of reflect. But certainly, what I've picked up from you are some of the challenges within your local geography, but also this sense of, you know, things done best at a local level and not trying to reinvent the wheel. So a lot of listening and a lot of understanding of what's currently happening and then making that work and making that scale. So I think that's come through loud and clear. And it'll be interesting to hear from colleagues to see if there's anything else they would have wanted within the geographical update, or that gives a sense of what's happening within Berkshire West. So let me open it up. I can see Saqib.
Thank you, Saqib Ali, Audit Chair. The health deprivation slide, I think, obviously on one of the slides, it comments that it's generally a healthy, wealthy area, but obviously the slides that you show, especially in Reading. So something that I wanted to draw on, I was in Barking yesterday and I saw a pull-up poster that was talking about discounted meals that were sponsored by the council to actually help people, obviously, in the time of, you know, cost of living crisis, you know, how that can be brought to more families. So I was just wondering whether there are any initiatives like that that you're aware of in our patch. So that's bringing perhaps the health sector working more closely with councils, but also the learnings that we might have in your patch with areas of deprivation, say, for example, in High Wycombe and other areas in our patch.
Thank you for the question. So there's a lot of work going on around sort of cost of living crisis, and each of the 3 health and wellbeing boards have kind of groups reporting into the Health and Wellbeing Board looking at this as well. And that's something that we can provide more information on in terms of the kind of the granular detail of what that looks like, and working really closely with our voluntary and community sector as well and social enterprises to really make sure that we are maximising the reach that they have into those most deprived areas. So I think that's definitely something that we are looking at. It's just not kind of coming through in the pack. In terms of learning, I think one thing that we are looking at the moment is around how we have and it's one of the enablers in here, how we are bringing together the information and insights that we have into our populations in a way that's kind of unified between all of our partners, because we have a lot of data. We have some fantastic data out there, but the next step is turning data into insights and actions, which we are doing. But sort of how do we take that even further, and working even more closely with our local authorities who have sort of ward based, as in council ward area based kind of initiatives as well, that are really focusing on some of those core 20+5 areas. So I think it's developing in Berkshire West. I think a lot is happening, but what we're really focusing on as the enabler is how can we make sure we're all singing off the same hymn sheet as public organisations, and therefore really prioritising the areas together in a coherent way.
I think it was Rachel next, and then I'll take Margaret, George.
Just very briefly, just to follow on from what Sarah was saying, we have commissioned what was the Academic Health Science Network, that's now Health Improvement Network, to do an evaluation piece of work on the inequalities funding that has been distributed out to places over the next 2 years, not to wait at the end of the 2 years, but in a very dynamic learning way. So some of that evaluation and shared learning of aspects that work in certain places that could be transferable, or aspects of transferable, will come up in a kind of constantly learning and improving way over the 2-year running of the various schemes.
Margaret Batty, Non-Executive Director, ICB. Really great to have this on the agenda, really interesting. Two related questions, I guess. So one is on variation. So Saki mentioned the healthy, wealthy perception of the area. How do you deal with variation in the 3 areas within West Berkshire? And because you mentioned, obviously, Reading, greater levels of deprivation than Wokingham, but is there a kind of, we divvy this up in thirds, or is there a focus on where the deprivation is greatest?
Very much the latter. So so from a BOB level, when this funding was allocated, it was based on kind of the national deprivation and various indices calculator that then says where we should best invest the funding. And then the same was applied in my patch across the 3 local authority areas. So we took an element of dislike the phrase, but top slicing, the things that we wanted to do consistently once that affected all 3 local authority areas. So the investment into general practice and the investment into the kind of programme project support for this. And then the remainder was allocated largely 50% to Reading and 25% to the other areas based on the prevalence of need in Reading and the others. And that's where I think it's helpful to have a really mature partnership, because we acknowledge that there are different needs in different areas. And we need to, certainly from my perspective and from our perspective as Bob, we need to be able to see that we are tackling the areas and levelling up, for want of a different phrase, so what's also respecting that there are some clear underlying needs within all of our areas that we need to target as well.
As an observation, I think that's an interesting challenge for Bob as a whole system, because when we take our 3 places, how do we take that logic and that concept and that thinking, or do we divvy up by 3, whichever way it goes, whether we look at the index of deprivation. But my supplementary, if I could, Sim, was about, you mentioned impact measures and looking for impact measures. And in terms of sustainability, it's really good to hear you think this is scalable, particularly, you're going through the 3 areas first in Berkshire West. But in terms of impact measures, it would be good to see, the numbers of people you think will be reached, the impact that this will have, cost benefit analysis and saving elsewhere in services. I'm sure that's coming. But I think in terms of future fundraising and convincing that this isn't just healthy, wealthy Berkshire West, this is worth investing in, it would be good to have some hard figures and KPIs.
So Absolutely. Public health partners in particular are kind of taking a lead with all of us around that sort of local evaluation of the impact it's had. So hoping that this will reach around 9,000, at a minimum 9,000 residents in the 18-month period. We're looking at the number of cardiovascular events that happen. So the number of heart attacks, for example, that then happen over the corresponding period. And that's an area where actually in a relatively short space of time, we're hoping that we'll see an impact because of the changes that are made to lifestyle that might then impact on high blood pressure, that then has a knock-on impact on those events. So whilst a lot of the preventative measures are probably longer term as well, and we've got some longer term measures we're looking at, it's also helpful to us monitor that in the short term as well.
And can I just come in on that? So when do you think we're likely to see that evaluation report?
So we are just mobilising at the moment. So it's something that we'll be monitoring on an ongoing basis but realistically, we probably need about 9 to 12 months to kind of embed the model, and then we're going to be monitoring it on a monthly basis as it gets up and running as well. I suppose that's another kind of take home message is it takes time to bring partners together and to develop something together in partnership. And I think at the start, I probably underestimated the amount of time we'd need to kind of make sure that we are all working on this and moving together. So that's just another reflection on this.
Thank you, Sarah. Good insight. Now, George, was it George? And then Minu, please.
Thank you, Sarah. It's George Gabriel, partner member for Primary Medical Services. Since these papers were released, I've had dialogue with our colleagues in pharmacy, optometry, dentistry. They did express a bit of disappointment that they aren't represented, particularly in the diagram on 1.2, because they're not part of the Berkshire West Primary Care Alliance, which is in essence more of a general practice alliance. So just sort of on that, and also with the fact that the Primary Care Alliance has got these 3 separate PCNs, how are you planning to engage with those parts of primary care that aren't part of the Berkshire West Primary Care Alliance? Is that going to be directly or through the alliance? And how can we make sure that the patients who reside in the areas where those 3 PNs aren't covered are equally able to benefit from what are outstanding schemes that you're outlining? Obviously, I've got lots more detail of them outside this room as well, but I think it would be a real shame if they didn't get the benefit of that too.
Thank you, George. And I think that is a fair observation in terms of the inclusion of pharmacy, optometry and dental, and something that I will be working with them on going forwards to make sure that they have a clear voice in the partnership locally, whilst also making sure we're getting the balance right between the work we're doing across the Bob patch. And I think this links into the kind of our operating model as an ICB and where the centre of gravity should sit for those conversations. So thank you, and noted, and I'll take that back to colleagues in those areas. From the kind of the PCN engagement, and I've just been discussing this with the chair of our GP leadership group actually, around making sure that we have those clear structures. So the alliance is one structure, but then also we're recognising that there are some things in the relationship with the ICB needs to be consistent across all PCNs and with all of the chairs of all of the PCN groups. So that is something I'm absolutely mindful of, and we're working to just make that crystal clear at the moment, because we wouldn't want anyone to feel excluded from this.
Thank you, George, for mentioning POD. They're very important that we get used to bringing them into the lexicon of primary care. It is relatively new, so you can understand why there isn't that natural inclusion. But for sure, the teams are getting used to insisting that definition of primary care now includes POD. Minu, may I bring you in?
Thank you, Chair. Minu Rani, Medical Director, Berkshire Healthcare and Mental Health Partner Member. It's more of an observation rather than a question. And my observation is there's no single organization which can meet the population needs, the variation in the needs of the areas. So it's a Reading versus, of course, West Berkshire and Wokingham, and the different needs of the population. But I think we shouldn't forget the soft factors and the impact that integrated care as a concept and the ICB as an organization has on this. So it has enabled, I think, all organizations, I don't mean just Berkshire Healthcare will provide the mental health and community services, but also the acute hospital, primary care, to be able to have these conversations facilitated by the ICB, the bigger events, but also on a more individual basis. And that ethos of integrated care runs through most of our discussions. It's much easier now to ask for something, to ask for help, and to try and meet those needs of the population which are varied in the area. So that's just an observation. I feel we're in a very early stage of the journey, and we hope things will even get better as time goes.
Thank you, Minu. Very useful. Sarah, did you want to come back for a final word?
Yeah, I think just building on that, because I completely agree. And that's why one of the enablers we really wanted to work on is how do you make sure all of our teams are feeling that level of integration that we are feeling as a leadership team as well. So people knowing each other, knowing who might be at the end of the phone if they pick up the phone to ask a question that might leave them feeling a little bit vulnerable between organisations. And actually, if you know who you're talking to, that's where real integration starts happening on the ground as well. So we don't want to lose the focus on that.
Excellent, thank you. I hope you all agree that that was a very useful insight for us. That's one of three. And I'd like to take up Margaret's suggestion. Once we've been through all of the geographies, we perhaps then can reverse back and look at the variation and bring up that question again, Margaret. That'll give us a chance to assess and give us a real sense of the difference of each of our geographies and the challenge that brings to a particular ICB like Bob. So again, thank you very much, Sarah. Thank you for the slides. Very good. Thank you. So moving us on, please. We'll need to move on to our next item, which is our approach to our future planning. So 24-25 strategic, operational and financial planning. I'm going to ask a little triumvirate, I think, Matthew Tate, Matthew Metcalf and Hannah to present this piece. And this is quite exciting for us because this is the first time that we have had a true sense of a board of looking further enough ahead to be able to have an impact on this plan. So we are looking for some approval here. So we need a clarity in what's being presented so that the board are able to give you your thoughts. So I think without further ado, you introduce it and we'll take it from there, please.
Thank you, Chair. So it's Matthew Tate again, CDA for Bob. So I'm going to kick off and then invite Hannah to add a bit of context and Matthew will come in on the financial framework as necessary. So I think, as you say, Chair, we've now done, I think as an ICB board, we've done a half-year planning exercise when we kicked off. The ICB, we did an operational plan last year and we're just doing an operational plan reset as we speak today. But I think what's different here is that we have the ICP strategy agreed and we have a joint forward plan agreed. So this is the first time that we're not principally responding to national guidance in terms of our planning process. Now, the national guidance has not been released at this stage. We are expecting it in December, but we pulled out in the paper some of the key aspects that we're expecting to see in that operational planning in terms of service delivery and improvement. And you won't be surprised to acknowledge some of the focus on elective care, continuing that recovery, sustained improved performance in the urgent and emergency care pathways, focus on cancer, diagnostic weights, and those ones that we're probably familiar with as a board. And also there will be undoubtedly be a commitment to a broader range of areas such as mental health improvements and investment and maternity issues. So all that framing will still be there, but actually to inform that and to focus our local plans, we now have the joint forward plan and the ICP strategy. And that's where we've been working, as Nick mentioned earlier, in terms of some system-wide discussions. So you'll see in this document, for the first time, we have a more locally focused set of system goals to add context to the national guidance around delivery and finance. So I think that's what we're asking you to support today, but I'm going to ask Hannah to add a little bit of context to those system goals.
Thank you, Matthew. So as Matthew set out, what we're trying to do here within the context of kind of the wider planning is think about beyond the NHS organisations. Do we have a shared sense across our system in terms of where we're going? And within the wider context of the joint forward plan and the integrated care strategy, what are the more discrete set of areas that we want to coalesce around and really progress particularly over the next year. So we focus these around our 4 objectives as an integrated care system, which actually are objectives that can only be delivered if we work together across NHS, local government, voluntary sector, research, and all aspects of our system. And we have held various conversations, as Nick mentioned, to brainstorm and work out what's our kind of 3 to 5 year ambition across these areas. And therefore, within that, what do we think we should focus on this year? And so we're in the middle of this system conversation. It's still ongoing, and we're bringing this to the board today to have another aspect of that conversation. And we bring this, I guess, half cooked in some ways. So we've got a sense here of the priorities and the areas that we want to focus on. But what we haven't done yet is refined them, translated them into measurable goals, and said how we'll deliver them. But we're getting lots of feedback as we speak from system partners in terms of how we do that. So what we wanted to do today is bring this to board and have the conversation here so that we can inform the next iteration before we start delivering these collectively in 24-25. Matthew, do you want to?
Oh, we'll just bring Matthew in, and then I'll bring open for questions and discussion. Matthew.
Thank you. I think the financial framework that we're looking at for 24-25 is pretty well known at this point, in the sense that we've known for some time around allocations. We know what the expectations set against those allocations. There are elements that are uncertain in terms of inflation and the overall efficiency requirement that will be required to develop nationally. Although we can make some assumptions around those. Yet, put in the context of the current financial climate, it's not hard to see how immensely challenging it is. I think that's all I really want to say. And obviously, individual lines of allocations or funding will flow through from national priorities in ways that we don't perhaps know, but we can again make some assumptions around. I think the detailed planning work required between now and the end of the calendar year is going to be pivotal in how we respond to the challenge going.
Right. So I think what we're asking for comment on today is looking at the system goals. Are they the right goals? Goals for the ICB and the partner trusts, and the context and the arrangements by which we're looking at setting this up. And just to reiterate, we start this process earlier, and which is much more comfortable for this board. And obviously, it gives us time to fully engage with all system partners. Money is going to be exceptionally tight. So the only way we can deliver for the residents is by working together, and that's hard. So we need time to be able to make those engagements. So are there any comments, please, or thoughts on this agenda item? Nick, do you want to just set us up before I bring in questions?
Thank you, and colleagues, thank you for that overview. This is an important opportunity for us as an integrated care board, and I think builds on some of the things we've said already during the course of this meeting regarding the need to actually start shifting resource, shifting people, shifting culture, shifting mindset, so we can support people more proactively. So it's the start of a proverbial journey. There'll be a limit to what we can do next year for very obvious reasons. But I think what is very clear to us sitting around these tables, and indeed to our colleagues working in our wider system, is that we can't just continue doing things as we are doing. It's simply not sustainable. So we do need to think about how we can enhance that offer in the community, how we can strengthen primary care. And it will require money moving, it will require people moving. Now, there'll be limits for next year, but my sense is our system partners are aware of the need to do this and are supportive of the need to do this. That's certainly the impression we've got from various meetings we've had, not least during our regular tripartite meetings with provider trusts, of which we've had a number in recent times. So I strongly support this direction of travel, and we're looking for the board to approve the paper as it stands at the moment.
Thank you, Nick. Can I invite further comment or any observations or questions? Rachel and then George.
Thank you, Rachel Sherman, Buckinghamshire Council. So I think the proposition around having system-wide goals is absolutely right. I suppose the devil's always in the detail, though. So my questions are: the proposals that sit before us, are they evidence-based, taking account of the local health and wellbeing strategies and the joint strategic needs assessment work we've already all committed to as a collective? Do we think that they are sufficiently focused? So some of the goals are pretty wide, and given our earlier conversations around limited resource, both people and money, we would all want to set off on a journey knowing that we could actually achieve something. So that is a bit of a concern for me. I don't understand, and you would argue, nor should I necessarily, the detail that sits behind them, because they are very broad, but the devil is always in the detail. And therefore, if we're asking people as individual agencies to sign up to support some of these goals, I think we really need to be very, very clear about what we're actually asking. A number of these feel as if they are intra-health, so for the health service in its various component parts, and some of them feel like they are broader whole system, and it would be really helpful to be clear about which is which. And then finally, I'm unclear as to where the overt agreement for this list will come from in terms of the individual organisations. That's all. Thank you.
Right, so there's quite a lot in there, but exceptionally good challenge around focus, delivery, who's accountable. Hannah, do you want to tackle some of what Rachel's asked to begin with?
Absolutely. Thank you, Rachel. This is exactly the conversation we want to have. So in terms of the evidence for them, that deeper work was done as part of the integrated care strategy and the joint forward plan, and everything you see on the page comes from those wider documents which were engaged and which came from JSNAs and health and wellbeing boards. So it's more the kind of system question is, and you're completely right to pick on the fact that these are kind of very high level at this stage. The system question at this stage is, are these the right areas we want to focus on? How we focus on them and what we focus on within each one is part of the conversation we are having now and we want to continue having. But I think there's a question I'd like to pick up with you around the governance of it. I think the path I see is that we will spend the time up to Christmas in terms of refining these. We've had a lot of commentary about the number of them. Is there a chance we can kind of distill them down? We could probably bring some of them together. Then for those which are particularly broad and vague, we need to work out what is the system value here. We've heard so beautifully from Sarah in terms of place delivery of CVD, but where actually, for example, for something like CVD, would a system perspective add value? We need to be really clever about making sure we're clear on those. So that work will carry on. And then in the new year, we'd like to bring it back to this board. And we'll also need to think about the system boards that it can go to for wider discussion. Catherine.
Just going to bring Catherine in.
Yeah, so Rachel, I'm coming back on your last point about the overt agreement. So it's something we've had quite a lot of conversation about, and it's that balance between, as an ICB board, we can and should agree our focus for delivering the plans for the NHS and how we want to prioritise things, but that is the scope of our authority. The wider system buy-in and whether other organisations wish to adopt this is part of that wider discussion, and we are it's being presented at the Integrated Care Partnership tomorrow for the similar sort of discussion, but we can't make any other organisation or part of the system say, yes, this is what drives us, but they can see what's influencing us, which bits they might contribute to, and it's that some of that joys of the governance and the system-wide working that we've got. But it was more this board wanting to be clearer that how we looked at our operational plan for 24-25 had a much greater eye on the future and was embedded in that integrated care strategy and the joint forward plan, and not doing the usual NHS reactive to the NHS England planning guidance. Does that help?
Happy with that, Rachel? Do you want to come back?
I think it might be helpful to have a broader conversation offline about the way in which broader constituencies are engaged in the detail in order for something to get traction. Thank you.
Well said, and we will bring this up at the ICP board meeting tomorrow. Again, we'll seek that wider engagement on just that, Rachel, and then come back again. Thank you. George.
Yeah, just a couple of comments. I think again comes back a little bit to Rachel's comment that some of the devil's in the detail. So first off, I think the workforce, it's good to see it explicit within there. I think personally, I feel a bit disappointed that the initial focus on it is on process as opposed to well-being and support. And I think that probably could be echoed, that view, by our workforce. I'd also, again, this is the detail bit, but, you know, good to have it explicit within there, whether that includes our primary care workforce, which are generally employed by, you know, hundreds of independent providers across pod and general practice, and, you know, what the offer is for them. So I'd kind of encourage that that's explicit within the final version of this, although I recognise it's not appropriate for here. The second is a comment around the tackling inequalities and the debate around the system level and what to use. And I think I'm always nervous when we talk about using primary care networks as the kind of unit of size, partly because actually they're at very various different maturities and doesn't always necessarily account for the needs of that population. For example, in Bucks, I think, you know, the opportunity Bucks areas and, you know, a focus around a broader area like Aylesbury can be much more helpful than looking at individual PCN. So I kind of encourage a degree of flexibility for localism in that decision making. And then the third comment is just around language. I think the language in this is really technical, and I think a lot of our residents would really struggle to understand. Actually, I think a lot of our workforce would. So using terms like anchors, you know, I think a really plain English language version would be really appropriate for this, and actually probably at consultation level, because I certainly had to go away and get my dictionary out and Google to be clear exactly what some of the terms meant.
Thank you very much, George. It is an ongoing journey for us to demystify the use of the language within NHS. And I noticed that a phrase that keeps coming up in the papers is core 20+5. And I'm sure a lot of our residents don't actually know what that means. So could I ask Hannah, do you want to just tell us and just reconfirm what that means? And we take on board the constant use of language, and we're going to ask our local authority colleagues to help us with this, because that's something that they're particularly good at. Thank you.
Thank you, Jules. I think those were kind of three really valid challenges. In terms of core 20+5, this is the national strategy in terms of inequalities, which is focusing on the core 20 most deprived population, and then the plus is around systems focusing on particular groups where they know they have local inequalities. And the 5 are 5 areas for adults and for children where there are particular areas of inequality that we should focus on, such as cancer diagnosis, respiratory health, etc. I think your wider points are really, really valid. I'd like to pick up some of the detail in terms of how we land that with you.
Any other comment? Margaret, please.
Yeah, thank you, Hannah and colleagues. I guess similar observations or challenges as others, one on aspiration and one on alignment. So the kind of realism versus aspiration, not just the financial actually, but the timescale. So I do applaud trying to have a smaller subset of goals, but implicit in that is that we're not doing everything. So in our plans, and so I think in future iterations, it would be useful to see explicitly what goals, areas, themes, geographies are we not doing, intending to progress as much this coming year. Also to have a kind of analysis of any deviation or assurance that there is no big deviation from the ICB and the JFP strategies. A cross check with our top risks. So the risks that we've got on our register now and coming for the forthcoming year, do these priorities, you know, speak to our risks? And on the time frame, you know, Rachel says devil's in the detail, but you know, we're not going to have smoking cessation free in the next 12 months. So what's the timeline? Are these goals intended to be for 3 to 5+ years? A lot of these things are very long term. So are we not committing ourselves, but acknowledging that these are not, you know, it's not sustainable to put resource into these things for 12 months and then shift this time next year to another set of goals. So the time frame, I think, would be really useful to hear about. And the reality of the room for manoeuvre and the resourcing. You know, 50% of our resourcing goes into acutes, I've read in the papers. So what room for manoeuvre have we got? It's not all about the money, but so the realism, aspiration angle and the assurance about timeline. Thanks.
Anna.
Thank you, Margaret. So I think one of the things that, and it links back to Rachel's point in terms of the kind of mix here between kind of NHS and kind of wider things. So some of this is about being actually quite practical in shifting where we've got risk, for example, in the system where we have real equity issues in terms of waiting lists. How can we use this to drive system attention on that? And that's actually where we're meeting. We're using our kind of leverage as a system to think about actually how do we meet one of our biggest risks and mitigate that together. So you can see that within it, whereas some of it's much broader, where actually we think that we could do a lot more collectively on CVD, where we learn from what Sarah's doing in Berkshire West, for example, and scale that up. But I take your point, and I think what would be nice actually in the next iteration of this is to think about the longer term ambition, think about the year's kind of action to get us there, and then what future kind of years might look like, but also being kind of the appendix version of that, tracking it to risk, and then thinking about how it maps to our broader strategy and the other objectives.
Yeah, thank you, Sakib Ali, Audit Chair. So the point I just wanted to make was obviously with the finances that we've got and for the rest of this year, the impact that it's going to have on next year. So I think we need to be cognizant of a board, both in the financial position and then the demand that we're going to have, because depending on what solution we come up with is how we're going to address the Secretary of State and NHS England's demand or request, then potentially that is going to have an impact on next year. So some of our aspirations that we're talking about today are actually going to be, they were already difficult, they're going to be even more difficult. So whilst we're talking about increased allocation, then on the other hand, the ICB is going to have less money. There's going to be deficits, there's going to be all sorts of challenges. And so I don't want to be pessimistic, but I just want us to be realistic on what we can achieve, both in the current financial year and as we move into next year. Anything that we push is not going to be another magic money tree on April 1st. It's going to be anything that we push over from the 31st will be there next year.
You want to come back on
just very briefly, maybe then hand over to Matthew. I think that's completely right. And this is, as Nick said, about being smarter with the resources we have, whether those are our people, whether that's we're running currently 3 different programs on a particular aim here, and we think we could kind of tackle the variation if we brought them together. Also, whether that's about improving a pathway, joining up procurement, just being cleverer about the resources we have in the system because of the resource constrained environment. It's not about doing a kind of shiny set of things with new money. We can't do that.
Thank you. Matthew.
Not much to add to that. I think it's a good challenge and we need to articulate it the way that people are looking for. And I think we'll, the next iteration of this will then draw out those key risk areas and how we're going to address them within planning. I don't think many of the risk areas will be a surprise to people, but I do take Sakib's last point that the constraints we're in today will have, and how we address them will have an impact on next year too.
So I think it's clear, there are huge financial constraints, but I do want to make clear that we must retain a sense of aspiration. Otherwise, we are not going to be able to move towards the prevention and our community care. That's where we need to push our resource out into the community. And we can't do that if we're always concentrating on the operational and financial pressures of today. We have to be mindful of them, but they cannot get in the way of what we are having to deliver for our residents. So this is where we call upon the expertise of our colleagues around this table in the exec, and more importantly, and most importantly, our colleagues within the system, because together we can work this out, but we must remain hopeful and aspirational so we can deliver we have to have an eye on what is possible, even if it is not possible in the short term. I agree that we need to be clearer about what is quickly deliverable, and we need to be clear about mid and long term deliveries, but we must have that sense, and we must give this system a sense of hope. So I hope whilst balancing the issues that we have. Let me bring Nick in first and
So
then Margaret.
Can I just confirm that the board is approving the direction of
Let me
travel?
bring Margaret in
Okay.
first. Sorry, Nick.
Margaret Batty, non-exec director. It was a really quick one, just on digital and data. I just wondered if that we considered that as a key unlock this year. And we mentioned population health management data and so on, but I just wonder if that requires a bit more of a push, because we've considered that as the anchor, the foundation stone for much of our future work. Thanks.
Well, just so happens, and I'll bring Victoria into the next section, we're going to be getting an update on that, and that should answer your question. So let's just close this off now. And I think I'll ask the question that Nick was going to. What we're seeking is an approval for the direction of travel. The fact that we're bringing this today for these discussions, and we will go away, take on board what has been said, and Hannah team will work on this. So do I have an approval for the sense of the direction of this paper, please? Yes, thank you.
And then in terms of the next iteration, when the board will have sight of that? January, okay. So we'll put that down as an action and we'll bring a revised version to the January meeting.
Thank you, everyone. Moving us on, we now have a primary care access and recovery plan. And Rachel Decaux is going to present this to us. And this is all about assurance. Now, Rachel, this paper was particularly long and full, and perhaps you'd help us and explain why that is, and what this paper, the purpose of the paper, and therefore what we can draw from it as a board. Thank you.
No problems, Chair, thank you. Rachel Decaux, Chief Medical Officer of the ICB. So a little bit of context setting. So in May of 2023, NHS England published the National Delivery Plan for Recovering Access to Primary Care in response to the growing pressures and how it was impacting patient access. Just need to be clear about nomenclature here. So primary care, when used by NHS England in this particular instance, refers to general practice only. It does not include pharmacy, optometry and dentistry, which is why there is no reference to it within the paper. This is unlike our developing system primary care strategy, which is fully inclusive of those domains and those highly valued colleagues. The reason this has come to board is twofold. One, to update the board on progress, but secondly, because there was a very specific request from NHS England to all ICB November boards that this particular document comes and updates. And the reason it is so long and detailed was because of certain areas that have to be included in terms of the assurance process for NHS England. And this document has been to region before it has come to board for further discussion. What it does is set out a programme of work to address some of the issues by enabling all of our general practice to implement a modern approach. The plan has been written in the context of our joint forward plan, and it aligns indeed with some of our aspirations within the general practice component of the primary care strategy, if you think about access or digital enablers. And it's split into four main components: empowering patients, modern general practice, how do we build capacity, and reducing bureaucracy. And I guess the case for change is, like many parts of the NHS, general practice is under immense pressure. I've said previously that across our footprint, activity is up by around 13%. And whilst as a system, we compare favourably in terms of same-day access and within 14 days of appointment with the national average, patient experience in our system has fallen in the last year and in 2022, again in line with the national position, but it's just an even stronger incentive that we need to do more, better and quicker. So I'll just pick a couple of components out of the various sections. So if we look at empowering patients, one of the areas is around self-referral pathways, and you can see detailed that we've the areas by which those self-referral pathways are in place and areas that we still need to work on by March 2024. We do have some issues around recording with the community services data set, which is affected baseline data and making it quite difficult to track, which teams are working through at the moment. Hopefully everyone on the board is familiar with the NHS app. It's one thing to roll it out in terms of technicality. It's another thing entirely in terms of optimizing the use of the functionality in the app, but also addressing some of the variations in uptake. And we've got huge variations in our population. So again, targeted piece of work around that. We've done a lot of work in expanding community pharmacies, which are an essential part of primary care. 80% of people live within 20 minutes walk of a community pharmacy, and there are twice as many pharmacies in areas of deprivation compared to affluent areas. We have an extremely successful community pharmacy program within Bob, over 4,000 consultations a month, and we're the second highest referring ICB in the Southeast. And that has saved already close to 1,300 hours of general practice time. So really appreciative of colleagues in community pharmacy, but appreciate they're under very similar pressures in terms of workforce constraints as other areas of the health service. Under modern general practice, there's a lot within the general practice IT, so you will be familiar with cloud-based telephony in terms of improving access for patients. Once again, it's one thing having the technical ability to roll out, it's another thing in terms of helping support practices to obtain the full functionality. In terms of access and improvement plans, all of the primary care networks and member practices co-developed and co-owned their improvement plans. And there are a number of themes that came out that they wanted to look at or needed support with, for example, around care navigation training, engagement with patient partner groups on access challenges and solutions. And so that has helped frame some of the support level offers going forward. And then to finally touch on two final areas, we have been building capacity with the additional roles reimbursement scheme. And across our geography, we employ over 932 whole-time equivalents. So these are people such as paramedic practitioners, social prescribers, but we know that there's further work to do, for example, in care navigation. And the final component is around reducing bureaucracy, which I'm sure we'd all be delighted to hear. And a lot of that is around the primary and secondary care interface. And the Academy of Royal Medical Colleges produced a report that wanted the primary care and secondary care interface to look at onward referrals, complete care, how patients are recalled, and whether there were clear points of contacts for patients. And working with chief medical officer colleagues across our providers, we have had very detailed returns from our providers on the huge work and progress that they've done to date and the focus on this going forward. However, as ever, it is very strongly based on relationships. It takes time to build across the system, and there is considerable variation in the maturity of electronic patient records, so systems within our providers that sometimes make it a bit more clunky at the interface than we'd like. The paper includes details on the finances to support the delivery, the comms and engagement, the ways of working of the primary care team, which is embedded in a population health management approach, the use of real-time data and continuous improvement. And clearly the health disparities piece is a golden thread throughout it. We will bring a further update to board in March 2024, but I hope that that gives you the framing and oversight of why this document's come as assurance today.
Thank you, Rachel. So just to remind the board that the NHS England have asked us to have a look at this plan to basically commit to the system being able to deliver against the national requirements outlined. So we've got to look at the programme structure as explained and described in the paper and the governance. So are they sufficient enough to deliver the changes expected? That's what's being asked of this board here today. So do you feel there's enough evidence in this paper to make us assured that this is the case? I'd just like to bring one thing up, Rachel, from a question point of view, and that is the importance of comms from the primary care into our patients. And I think there's probably some improvements that could be made. So how are we engaging with how primary care introduce new comms, new apps, new platforms to their patients in a way that will enable them to adopt that quickly? I just wonder what the comms element is within that, and whether we're helping with that. Is there someone that could answer that question?
I'm happy to start off, because absolutely, it's absolutely key in terms of how we do that. And there's a number of ways that the team looks at doing it, whether that's with workshops, with patient participation groups, with focus groups, sitting down with practices in terms of them identifying areas that they would appreciate support with. So it's about tailoring some of the support depending on the patient population and what's needed. Tori, I don't know if you want to come in from a digital perspective.
Hello, Victoria Otley-Groom, Chief Digital Information Officer. Yes, very much so. It's absolutely critical that our local people and citizens understand how they access our services. And I think we have started some of those conversations, but there's a lot more we could do. As part of one of the initiatives in digital, which is called the Secure Data Environment, there is some funding to support a wider conversation for our citizens across our geography to support that. And my approach and view would be, obviously in discussions with colleagues, is that we use that as a wider engagement, asking how do they need to access our services? What's the best way? How do they do it in a simple, seamless way that's effective and supportive? So agree, we've got more to do. And if I may, we take that away and we can update going forward on the progress against that. Thank you, Chair.
Thank you, Victoria.
Can I just say one other thing? So we work very closely with the general practice leadership group within the ICB in terms of constantly getting their feedback in terms of preferred approach, because I think it's just really important to be hearing from those that are on the ground and their population.
Say, George.
Sorry, apologies. And also just to thank Rachel for clarifying regarding pod, because that query came directly to me last week from our pod colleagues. 2 questions stroke requests really for considering for future iterations. The first is I think it's been recognised that the success of the community pharmacy consultation scheme, but actually the feedback we get from the ground is that this is incredibly patchy, probably around 2 reasons. One is that there are areas with poor community pharmacy uptake, and we know there's another community pharmacy shutting, I think in Datcham imminently. So there's concerns about the risk of driving health inequalities, because areas of greater deprivation tend to find it more difficult to recruit pharmacists. And along with that, we've got 40-something practices who are dispensing, which by definition means they've got populations, often frail elderly populations that live more than a mile from their local pharmacy, which essentially means that they won't be able to access this scheme easily, which increases the pressure on those rural practices, which are also finding increasing challenges in recruiting GPs in particular, and practice nurses and local staff who obviously they have a smaller pool to pull from. So it'd be interesting and whether there could be any consideration for how we might be able to mitigate in Bob those particular 2 population groups that really struggle to benefit from the community pharmacy consultation scheme. The second is regarding the primary and secondary care interface, and I think again, you know, we appreciate that particularly in Berkshire, West and Buckinghamshire, we have really very mature primary and secondary care interface groups, which are really effective. The request that's come from colleagues, which is around 0.66, which is that the measurements in this document relate to the ones recommended by NHS England, but there's been a request from colleagues as to whether we could add our own Bob measurement of the effectiveness of the primary and secondary care interface, perhaps by explicitly looking at those 4 areas and marking how many we have been successful in across the trusts in our area. So, you know, for example, you've stated in here that we've got self-referral to 1 out of 3 musculoskeletal services in Bob, but actually what you haven't stated is how many of our hospitals have the ability to send fit notes electronically, and those 4 markers, it's believed by my colleagues on the ground, would be very good markers to be very explicit about in the measurement of the effectiveness of primary and secondary care interface. So I don't know if we could look at that for future iteration.
Rachel.
Yeah, thank you, George. And we'll take away for further discussion, I think, the community pharmacy consultation scheme, because recognise that variation and also recognise that, frankly, in some areas, the fragility of community pharmacy services. I think the primary secondary care interface, I think it's just really important to state it's a two-way dynamic. So there's asks of our secondary care colleagues and there's equally asks of our primary care colleagues. And you're right to call out the historical variation across the geography. But I would also like to kind of commend particularly the OUH in Oxfordshire for having a renewed focus in this area and in appointing in terms of an interface liaison, which I would hope would start to make inroads to some of the historical issues that have been faced in that part of the patch. I think I'd be keen to make sure that we are delivering in accordance to what NHS England has asked us to deliver in the first instance. And then I'm very happy that we start to drill down into specifics following on from that. But I'm really keen that we get the basics and the foundations right across the whole system first.
Noted. Rachel, did you have your hand up before, Rachel? I didn't see. Let's take you and then we'll come over here to Rachel and I'll give Nick the final word.
Thank you, Chair. I was just going to commend and comment on the additional roles reimbursement scheme. So all 51 of our primary care networks have submitted robust workforce plans, and I don't think we can underestimate the challenge around that and how integral the role of the system, just going back to the kind of priority goals that we were alluding to earlier in developing that integrated workforce and how we should be supporting and enabling some of that. And I think it's a real credit to the team within primary care that they've enabled those workforce plans to have been developed and shared in the time that they have.
Thank you, Rachel. Rachel.
Thank you. It felt a really comprehensive, robust summary of action to me. Just a couple of observations, and again, happy to discuss outside of the board meeting. It does feel with primary care and lots of other services that we provide to the public as if in some ways we're still providing them in the way that we think they should be provided. And so I was really interested in the take up of the app use, for example. And I was thinking about whether or not we're involving schools in talking to young people about how they can use an app, because it feels as if that digitally enabled access to healthcare is absolutely what younger people are interested in, rather than turning up at their doctor's surgery. So perhaps we can have a conversation about how we might increase that further, particularly targeting those young people who are furthest away from receiving healthcare proactively or reactively. Secondly, I didn't see anything in here, and forgive me if it's in, about use of kind of video consultations. So I know we talk about telephone consultations, but increasingly, of course, private health services have got a menu of services for people who use those in relation to video conferencing, which is much speedier. And I just wondered what our appetite was for that on our patch. And then finally, there is reference in the report to a relatively modest amount of money that's been received for capacity building, and a reference to estates, primary care estates, the system development funding of 5 million. And I wondered at what point estates planning, if at all, was going to come back into the board. Thank you.
Rachel, respond to Rachel.
Thank you, Rachel. And as ever, just really, really helpful comments and insights. So would really welcome a conversation around the schools piece and targeting certain sectors of the population outside of this. Just a brief comment on video consultations, and George may want to come in on this. So during COVID, we saw an exponential rise in video consultations, and actually it also meant that our practices were all equipped to be able to deliver in that way. Since, thankfully, the COVID pandemic has passed, we have seen a return to face-to-face consultations. Now, that doesn't mean that video consultations aren't an option. It's just that the preference has switched back to face-to-face or telephone consultations where appropriate. But the functionality in terms of being able to do them still exists. But George may want to comment. I may look to colleagues that are closer to some of the estates piece, because primary care estates is part of the wider estates strategy, which Matthew Metcalfe may wish to comment on. But absolutely welcome those comments and questions, Rachel. Thank you.
So first, actually, on schools, we have got some very proactive practices starting to do that sort of work, particularly around health education and things like that. So I think that would be something I'd be really keen to be involved in as well, because I think, unfortunately, again, those areas that need it are probably those areas that are least likely to receive it. So I think with video consults, and I think it was at my first board meeting back in the summer, we had some data around this that showed a really low uptake of it. I haven't seen any surveys or anything similar, but certainly experience on the ground is that video consultations just generally aren't that popular a modality, that usually it's a case of telephone is fine for a majority of things that can be dealt with remotely, and if they can't be dealt with by telephone, then either a face-to-face or a photograph being sent in is usually adequate. So we haven't seen that appetite. The functionality does remain, but I haven't seen any specific evidence to say actually that's not what people want. So that might be a piece of work to consider.
Rachel, then just quickly.
If I can just come back on that quickly, we started the meeting by talking about personalised care, and I guess my thinking is actually, if it's easy to offer people a choice, why aren't we offering them a choice of what works best for them? And we know that video and phone consults feel as if they're more efficient in terms of volume. Face-to-face, clearly, we would always want to provide for the public, but I'm a great believer in choice wherever it's possible. Thanks.
Noted. Thank you, Rachel, for that pushback. Let me give Nick the final word because I need to move us on. Oh, sorry, Matthew, did you want to say something? Yes, please do.
Strategy. My suggestion is March for the estate strategy. I think the board will have the opportunity to see some of the things that are coming out of that in advance of that as part of planning for 24-25, but nonetheless, we're heading.
Yes, there's been a couple of requests actually about that, so that'll be very welcome. But I think the board will need, as you say, some information before we get to March, because it is very complex. Thank you, Matthew. Last word to Nick, please.
Yeah, and Rachel, thanks for this. In relation to the additional roles reimbursement scheme, it looks as though we've over-recruited, which on the face of it is great. Is there any work in train to evaluate the impacts of these roles? Because the actual increase in overall workforce is significant. And anecdotally, at least, I get the sense that not every practice sees the full benefit.
I think it's, so first of all, I think it's really important to recognise the value of the different professional groups in these schemes. Secondly, given the demand that has increased by 13% in general practice, the fact that we have held our access would not have been possible without the additional recruitment to these roles. So in terms of benefit, we're seeing it in terms of being able to hold access. You are right to pick up because all of these additional roles require adequate supervision and support from the practice, and therefore before such individuals are taken on, we check quite carefully whether the practice has capacity to be able to do that.
I suppose just wondering whether there's a national piece of work looking at the evaluation of the new roles.
Not that I know of, but I can take that back to region to inquire.
Thank you. So do I take it from the conversation that we are satisfied, we have the assurance that we need at this stage on those deliverables given this paper and Rachel's contextualizing of this? Thank you. Move us on. I realise I'm over by 5 minutes, so I'm going to ask that we take our break 5 minutes later to give Victoria the time to be able to just update us on that strategy, if you don't mind. Thank you, Victoria.
Thank you, Chair. My name's Victoria Otley-Groom. I'm the Chief Digital Information Officer for Berkshire, Oxfordshire and Buckinghamshire ICB. Thank you for asking us to provide an update on the digital and data strategy. I'm making an assumption that colleagues will have already read the paper, and I'd also like to add my thanks to Ross Fullerton, who has departed and I have now joined the organisation, but he steered this work with a lot of colleagues, and I'd just like to note my thanks to him for his contribution to build this. Again, he and colleagues prepared this paper, and having reviewed it, I think there's some really excellent things. There's additional things I can provide over the coming months, and I will do that. In regard to the strategy, colleagues will be aware it was there to address a number of set challenges, particularly around the fact that we didn't have a single strategy, that we had different strategic goals in each of our 3 different areas. And also it was a very, very fragmented landscape, both around provision of digital and ICT services, around data and analytics, but also how we plan, lead and deliver digital enabled change across our geographies. And again, the strategy was very much there to start to build a foundation about how we deliver where we need to these together. I think colleagues will be aware there's 3 main themes to this: how we digitise our services, how we connect our services, and lastly, how we transform. And the goal of all of these, as with the other papers, is to improve access, to improve experience, ensure that we deliver these that are value for money, and identify where there are opportunities for productivity. And Margaret, I welcome your comments earlier in regard to the opportunities around digital and data, and myself and Hannah have already been in discussion how we add that into the group, so thank you for that. In regard to the work done to date, there's sort of 5 key themes I would like to pick up today. First of all, that as a lot of momentum has happened over the last 6 months, and a lot of discussion, meeting together, understanding the collective problems and convening. So I'd like to go through what we've done in regard to the improvements to governance, to engagement, delivery, finances, and lastly, how we propose to deliver in the next 6 months, and also what we're going to do in the 1.5 years and in 3 years. So first of all, in regard to governance, colleagues will be aware that there wasn't a single joined up governance, and to deliver these capabilities at scale, you need governance that has trusted partnerships, both with the leadership, but also in our individual providers and also at place, and also depending on what the programme or project is. So we now have established a single digital and data steering group with leadership from across the system. And this is a multidisciplinary leadership with clinical leaders, executive leaders, as well as digital and technology, digital and technological experts. But this is around leadership and guiding our strategy. We also have developed and has now met several times the digital and data delivery group. And that at the moment we have about 16 different programs, and that gives us the oversight, but also the assurance that we're on track to deliver those as outlined in the strategy. And having attended the first group, I was really impressed by the conversation, the buy-in and the engagement to start to deliver these quite complicated capabilities at time together. So it's heartening to see it's setting us up well for the future. In regard to stakeholder engagement, and again, welcome the comments earlier in regard to how do we engage with our citizens. Previously, when I worked in London, we did a citizen engagement exercise, and we published a document about what do citizens want from data, digital, how they access services, not only how their own data is looked after, but how we use it to help support planning, research. And it's very important that we hear that voice. So in the next 6 months, that's one area I'm going to look at carefully and closely to make sure we have that voice. It's not to say it's not there, but it's maybe not as loud and as broad as we need to hear. In addition to that, there's been some excellent activities convening partners together to not only to obtain buy-in for the strategy, but also to look at how we set the stall and deliver this roadmap together. And there was a digital and data summit. I'm just going to hold up the brochures, which was over 200 individuals attended. I was very fortunate even before I started to be invited and speak at that summit. And really, it was a really energizing event, and where clinical leaders, voluntary sector, local providers, charities met, and we talked about the opportunities for digital and data and leading that together, but also about and showcase some of the activities happening. Oxford University hospitals, looking in our social care settings, and also initiatives happening at place and with partners. And what was really heartening to hear was that everybody was committed to how we do this together. And that's quite rare, and that's quite an extraordinary achievement for the system already to start to have that buy-in. In regard to programme delivery, mentioned the 16 key programmes. Having joined the organisation 3 weeks ago, I've been reviewing these programmes and doing so until Christmas, and just making sure that we're really assured that we are going to deliver the plans. Some of them have a dependency on investment, some which is coming, some which is not. So I'll be carefully looking at that. What's important in regard to that is, are we confident to deliver these much needed capabilities as outlined in the strategy? My initial impression is broadly yes, but I will obviously get into the detail and we'll address that going forward. In regard to the different capabilities, colleagues will realise the 3 main strands is how we digitise our services, and in particular, post-strategy, there was a digital maturity assessment completed. And that was completed by all our providers. And we now have some new evidence and information about what is the absolute capability have, rather than when this strategy was written, that there was an anecdotal assessment. So again, I will be taking that information and baselining it to make sure that we have a robust roadmap going forward. Nothing in the strategy is broadly offline, but it's just making sure it's evidence-based. And then in regard to the specific areas, we've got our EPR maturity, which is our electronic healthcare records. So where we keep the information about our patients in hospitals, primary care and other care settings, for example, community and mental health. We have a good maturity across parts of our system, but we need to level that up. And there's some investment being sought in 2 areas, and that is on track, and we are proactively managing that as we speak. In regard to adult social care, there's a real acceleration of that. And historically, we were looking to try and do that in 18 months, brought that forward now, and that's going to be delivered by March, 80% by March of digitising social care. So that's a real plus, because we want to connect our system together, and particularly for the most vulnerable adults, sometimes children, but more often adults and older adults, is making sure they've got that joined up care information across the system. We also need to look at our common infrastructure, and that's the bolts and nuts, the wires, boxes, tin, whatever you want to call it. But ultimately, there's a lot of complexity there, and it's quite an old lot of legacy systems. But there's a new group meeting together now of all the technical leads across our providers about how we look at where there are synergies and we can converge going forward. And I joined the first meeting 2 weeks ago, and there's a real appetite to look at where can we bring things together, not necessarily converge, I think, but certainly look at opportunities, particularly around a shared Wi-Fi and cyber capabilities. In regard to our workforce, we've done some initial work. We think there's more to do, particularly around what we call upskilling of our general workforce, but also our DDAT workforce, digital data and technology workforce. There's about 950 individuals across the system, and they currently have some development, but they don't have an ability of a professional set of services. So we're looking at how do we upskill that workforce and make sure they champion change in each of their locations. Connecting together, we're looking at shared care records. Again, we've made some good progress. We are just on the cusp before Christmas of the last 20 practices in Oxfordshire being able to connect and agree their data sharing agreements. I'm looking at Claire. And this is really fundamental, because it starts to be able to build that single picture of care that's over different locations. So with social care, with primary care and with secondary care. And once we have those data sharing agreements, we've got the technological capability, but it's also about how do we change how we deliver care with these capabilities. And this is also important to make sure it's not just our physical health services, but mental health services need to be included. And some of the work with the investment we're trying to find with Oxford Health to try and do some enhancements to their community and their EMIS systems is also really required going forward, particularly after the advanced issue last year. So some good things in progress and just making sure we're on track to that. And then lastly, what we need to do is look at how we transform our use of data. Colleagues, I think, are familiar with the fact that we maybe have got quite a fragmented set of data capabilities. And what I'd like to do is, not here today, but is to outline the 4 main principal use cases of types of data as a board, so that we're clear about how we're addressing each of those, because there are different initiatives in place to address those. But how we not only look at direct care and care planning, but we also look at our use for operational planning, for academia and research, and lastly, population health management. There's some good green shoots in place, but it's how we accelerate that going forward. And then lastly, I'd just like to say about next steps. So I think it's how do we secure the investment? We have investment in place for running our day-to-day services, not large compared to industry, but broadly sufficient. But how do you get that extra investment to take on the bold agenda that we've just discussed and accelerate our ambition? So it's identifying with Academic Health Science Network and partners where there are opportunities to do larger bids. And that will be a focus again in the next 6 months to how we secure more funding that enables us to accelerate this agenda. And then lastly, I'm happy to take any questions, but if I could, I'd like to ask if I could come back and give an update in 6 months, once I've rebaselined the plan, once I've made sure there is alignment. Broadly, it looks really good, but just to do that due diligence myself. And then lastly, I've had a chance to talk and meet with partners. I've already met partners, and there's so much capability in this system, but it's how do we harness it together and deliver on this agenda. So if I may, and I'm happy to take questions. That's it for now, Chair. Thank you.
Thank you, Victoria. And yes, absolutely. We did commit to the strategy being brought back twice a year, just so that we can keep an update. And remember, this was one of the first strategies this board signed off way back in May. So we're seeing now the iteration, and it's really great to have that update. So let me ask for any questions or thoughts before I just get a sense of whether members are assured about what they've heard and what you've talked to us about. Thank you for the insight and the honesty. We see digital as a massive lever, and we really welcome your comment about getting residents' views on what that looks like and what it means to them.
Thank you, Chair.
Any questions? Minu, please.
Thank you. Very clear strategy, actually. When we talked about residents, first thought which comes to my mind as a member of public is, when will I have access to my patient records? And I think it's variable, and I know of all the arguments for and against, but I just wondered how we're doing in Bob. Do we have a picture of how many of our population has access to their own clinical records?
So an excellent question. I don't have that information to hand today. It should be something we should have to hand. I can tell you personally that it is possible to have access to your personal records in London, and it also is in Surrey. I will find that information, come back to you, but it depends on whether you've access to the NHS app, and then secondly, what your local geography and what's connected. So depending on where you live will depend on the answer, but we should have a metric to that. And also particularly since the end of October, with access to primary care records, that prospectively, that's going to again change the dial on who can or can't access that. So could I answer more specifically outside of this committee? But broadly, yes. I can't give the absolute number today, but a really great question. Thank you.
Thank you, Minu. Very, very pertinent. Rachel.
Thank you. It feels as if there's an enormous amount of work underway on this topic. I guess what will be really interesting from my perspective in the next update on this is to understand what's going to be different for organisations as a consequence of the work, and what is going to be different for the public as a consequence. Yeah. Because by its nature, it's obviously quite a techie summary, and making it kind of real, I think would be really useful. And then my second observation is it would be helpful as part of this work at some point to have a broader sector conversation about the use of artificial intelligence and where we are on that as an NHS, but also as a broader public service. Thank you.
Excellent. Thank you.
So two really excellent questions, and thank you. So yes, I would like to introduce more around stories and how it makes a difference going forward, particularly for local people, for clinicians and our workforce. So I think that's a really excellent suggestion, and welcome that. And if I may bring that back next time. AI is a huge area. There's a lot of complexity, but it's also quite simple in other ways. So I think it's having an agreed narrative that we all understand it broadly. There's already quite a number of really innovative activities happening across this patch, but I don't think we have a single view. So again, I think that's a convening activity that we could do to bring something together. And we're uniquely placed here that we've got some excellent institutes and some excellent universities that could pick that up, as well as our partnership with the Academic Health Science Networks and the Hill. So if I may, that would be an action going forward to convene something for partners that we could address that. Within this strategy, there are areas already that are supported by artificial intelligence, for example, DORA and other activities which are uniquely built and developed here in Bob. But I think we don't understand the breadth. And again, colleagues in Royal Berkshire, who have got a number of remote process automation activities. So quite a lot of innovative work there. So there are those areas, but it's how we bring it, showcase it, highlight it and accelerate it going forward. But thank you for your question.
Final word from Nick, please.
Sorry, thank you for this and for picking this up so quickly, given you've only been with us for a couple of weeks. I suppose what you just said, or rather leads into what I was going to say. I'm really keen that this strategy builds on the unique capability we have in our system, not just in terms of academia, but also in terms of what some of our provider organisations are doing. We had a tripartite meeting with Berkshire Health last week, and I was really impressed to hear some of the digital innovation that's ongoing in that organisation. I think it's automated vocal technology, if I'm right, Minu? Which could be an absolute, game changer. Yeah, exactly. And it's how we harness that and how we scale things up. And ensure that we can roll out best practice and do that at pace, because this whole digital agenda is absolutely fundamental to how we put things on a more sustainable footing going forward. So thank you for this, and we look forward to the update in 6 months' time. I'm
Thank
sure we'll
you,
speak
Nick.
before.
Yeah, and thank you. And I think it's about how we curate and are clear about where the big areas are and the opportunities and how we share that learning. So we're a learning system, not just from individual pockets, but we look to scale it where it is evidence and where we have funding to do so. But thank you. Yes, I will do. Thank you.
Thank you, Victoria. One request from me, when you're ready, maybe a resident story, going back to Rachel's question about how this digital and data really impacts powerfully on our residents. Maybe we can pick that up in a resident story that will illustrate Rachel's comment. Thank you.
Yeah.
Thank you, everyone. We're running slightly late. I'm going to give you a 10-minute break, and then back here for the final portion of the meeting, please. Thank you. Right, welcome back, everyone. Thanks for rushing back. So we move into the performance element and the operational performance now. So I'm going to ask Matthew Tate, Rachel Corsett and Rachel Deco, our triumvirate, to do the honours, please, in presenting. And this is for our assurance that there is grip and control in the system. So let's hear what they say, and then we can open it up for questions afterwards. Who is going to start? Matthew, thank you.
Thank you, Chair. So I'll start and give a quick overview of urgent and emergency care, elective cancer and diagnostics, then hand to colleagues to pick up broader issues. So, and I will keep it brief. There's lots of information in the pack for board members to consider. So urgent and emergency care, we saw a very pressured system, and you'll see that from some of the key metrics and delivery. So we have seen a deterioration in some of our key performance metrics, and the particular one that's pulled out in the pack for focus is the 4-hour target. So we have seen a deterioration in absolute terms over the last month, and that's continued during recent weeks as well, and that's moved away from our plan as a system. And to remind board members, we're seeking to get back more consistently to get to a 76% target. That's the operational plan goal. In terms of some of the challenges we're seeing in the system, we're still seeing relatively high levels of attendance. If you look back at annual trends, we've seen some problems with flow in the systems across the board, and a number of staffing issues, both in terms of some of our supporting services, such as urgent and treatment centres, and within our hospitals that have added to some of the pressures. So in some sense, it feels like we've got some of our winter pressures coming in slightly earlier than planned, and certainly some of the numbers in 1 or 2 of the patches on 1 or 2 of the days have been extremely high. In terms of what we're doing about it, we do have the winter plans that are beginning now to be implemented for an additional surge capacity and surge beds in the system, and all 3 of our trusts and indeed systems in terms of local geographies have well developed urgent care plans and responses as we move more formally into the winter period. So lots of hard work going on, a real challenging environment, but a continued focus to manage effectively and safely over the winter and get into improved performance. I suspect now as we move towards spring, we will have some challenging performance over the winter period. In terms of elective care, we continue to drive to work to reduce the waiting list, and board members will be aware of the impact the industrial actions had on the availability of capacity across our system. And the numbers you have in the pack really demonstrate that challenge of the system. We are seeing our long waits increasing, and we are going off plan in terms of our commitment to remove all 65-week waits by the end of this financial year. Again, I think the focus now is really to protect elective capacity as we go into the winter. We have had a real focus on outpatients over the last few months. We've got lots of waiting list validation going on to try and be clear that we are treating the right patients in the right order. And obviously, as Nick outlined earlier, at the moment, we haven't got any planned dates for industrial action. So there's a chance to really focus on that activity as we go through the winter months, bearing in mind that we will face urgent and emergency care pressure. The trusts and we work as a system well on a number of productivity areas. Perhaps the 2 I'd pull out is a focus on theatre productivity. We have a well-established group looking at theatre productivity across the system. All of our local trusts have updated and submitted theatre improvement plans to the regional team, again, to share and learn best practice. So a real focus there. And part of our transformation work across the elective care board is looking at day cases as well. So those focus specialties in urology, ENT, part of that capacity and demand match is going to be focused on the use of day cases. So I'm confident we are seeing a focus on productivity internally, but also a use of insourcing, outsourcing, and the independent sector to maximise that capacity as we go through the challenge. And that always has to be balanced with the financial environment as well, as I'm sure board members can appreciate it. On cancer, again, some challenging areas, some excellent performance on some of the targets. So I should acknowledge Oxford's sustained performance on the faster diagnosis standard, which is some of the best in the region and in the country in terms of those areas of performance. Where we have seen a slow deterioration in performance is the long waiters, particularly those over 62 days, which is a key operational targets in terms of getting back to pre-pandemic levels. So all of our trusts have been struggling over the last couple of months with industrial action on those numbers. Again, there is a focus there and a renewed matching of capacity as we go into the last 4 months to drive those numbers down as far as possible. That has been a focus for the operational planning reset, which Nick referred to earlier, and we're still finalising the numbers there. But we have Rachel DeCoe and myself are looking at increased focus on that, making sure that we have got additional assurance across the three trusts on their cancer improvement plans. So we'll be looking at a direct executive oversight from one or two of us over the next few months. And we've also put an additional reporting line into the clinical programs board for a cancer delivery and change program as well. Because we do rely on the Thames Valley Cancer Alliance, and they do have some vacancies and constraints in their team at the moment. So we're just strengthening that. On diagnostics, again, this is a set of challenging areas. So sorry, it's all of these areas continue to be challenging. Diagnostics, we've got particular pressure in Buckinghamshire Healthcare Trust in terms of their endoscopy, and they do stand out both locally and regionally in terms of the performance for 6-week waits. They again have got some access to additional funding and additional MRI capacity that should stabilise those numbers and start to bring them down to a more acceptable level towards the year end. But for endoscopy, that is a bigger strategic piece that we need to work on across the system around long-term capacity and capital investment. Bear in mind time, Chair, that was my very quick summary. Hopefully that gave the board an idea of where we are focusing and some of the challenges we've got. And I will hand to Rachel Corser.
Thank you, Matthew. Thank you, Chair. So Rachel Corser, Chief Nursing Officer here at the ICB. There's a few things I'd like to pull out from the report. Firstly, our focus around mental health, learning disabilities and autism. You'll see that we continue to report an increase in demand for those services, and that the numbers of particularly our children and young people waiting for access to assessments for autism and ADHD diagnosis is growing, and you'll see that that is one of the areas of focus within the system goals that we heard about earlier for a number of reasons. What we're seeing in and along the mental health, learning disability and autism pathways is in some cases up to a 200% increase in demand, and it is outstripping the additional capacity that we are putting into those services. So constantly working on new models of delivery, and as we heard at the last board, the Mental Health Provider Collaborative is our vehicle for helping us to deliver on some of those challenges. And indeed, only 2 weeks ago, we met across the system with key partners feeding into the Provider Collaborative to agree some key ambitions and priorities in a couple of weeks. So I think just to note to the board that the demand and the challenges around meeting that increasing demand within the system. You'll see in the report the work that highlights where we are against with the variation we're seeing in continuing healthcare services, particularly across the three of our geographical areas. We are working with our colleagues at NHS England to do a review of that variation, starting within the Berkshire West footprint, and will feed in through our governance architecture the recommendations that will come as a result of that. Then thirdly, just to highlight, you'll see there's some new slides in here highlighting some of the outcomes that we're reporting around maternity and neonatal services. And welcome Tori's conversation earlier about with the focus around data and digital. And I think this is just an example where we have really different ways of reporting and trying to get a united measure that highlights the same thing has been challenging, but we've drawn on areas that we know particularly our regulators focus on, so focus around induction of labour, some of the choice and some of the areas around inequalities, not least because we know that's an area that our colleagues at the CQC focus on. And Chair, as you mentioned, one of our partner members is absent today because one of our providers is having their own inspection this week, and that will then be the third and final one of our acute maternity services that will be having CQC inspections of the planned CQC maternity services. Then lastly, just to highlight some of the progress that we're making within the quality and safety agenda. So you're seeing here some a small number of metrics, but I think the thing that I just wanted to draw the board's attention to is the progress that we're making around implementation of the patient safety incident response framework. Our partners at Oxford University Hospitals Trust are leading the way in implementation of that, and then we'll be bringing through system quality to population health and patient experience, the progress of the other trusts in implementing that. And then my last point is in response to what we've heard already around the increasing number of patients waiting for care and services, and that remains a focus for us within the system quality group and through the population health and patient experience committee, so that we've got sight of the harm that might be resulting from those waits and how we then respond to that in terms of pathway intervention, particularly with the inequalities that might be coming within any of those pathways. They were the areas from me. I'll hand over to Rachel.
Thank you, Rachel. Rachel, Co-Chief Medical Officer for Bob ICB. So I think that we've probably covered general practice in sufficient detail in an earlier agenda item. So I'd just like to draw 3 brief points out from the pharmacy, optometry and dentistry areas. So dental access, whilst improving, is challenging in the sense that there's been a number of NHS contract handbacks, and that has predominantly affected capacity in Oxfordshire. There's lots of things that we're trying to do to address that through paying practices if they overperform, recommissioning the lost activity, additional access sessions and flexible commissioning, but it's something that we're keeping a very close eye on. In terms of pharmacy, you will have seen in the news in the last week or so that the Pharmacy First launches in January 2024. So that is that encompasses what we currently know as the community pharmacy referral service, which includes urgent repeat medicine supplies and also NHS referrals for minor illness. But it will also include 7 new clinical services and pathways such as sore throat, urinary tract infection in women and sinusitis, to name but a few of them. And that is subject to digital systems being in place, but that's quite a shift in terms of the focus on the community pharmacy space. And then in optometry, we have established that direct referral process for optometry into secondary care services, which helps to not only have a more streamlined experience for our residents, but also free up general practice time. That across our system will be fully established by the 1st of December, and a huge amount of work has gone into that across teams. So those were the main bits I just wanted to draw out very specifically, but of course happy to take any questions.
Thank you for that. Just a couple of points before I open it up. I note that the quality section continues to develop, and I know, I think, Rachel, you're very keen to make sure that it's fit for purpose and for this board. And also there's been a Population Health Committee request that we review the report to link into the 4 aims, so show clearly how each of the sections link back into our 4 aims as an ICB. And we're also looking for a board member to sponsor the performance and quality report, again, for that continued involvement and focus that the board would want for the sections that they need to see. So lots of work. We're a learning organisation and we want to keep iterating until we finesse the reports that make them very useful and easy to read. So I think we hear that we're very challenged operationally. And I think what, for me, I welcome the focus that you're sort of engineering, if you like, from our providers. But I think I'd like to ask for more assurance from the provider land in terms of what their mitigations and them trying to, you know, get back to plan in terms of the challenges that there are with regards to our moment in time. So it's just something to think about, Matthew, in terms of, you know, how we seek further assurance from them, and are we getting the assurance through the subcommittees that we need, that give us the confidence to understand that this is a limited sort of, you know, operational blip, or how long we foresee this for. We understand the circumstances and we know very well that industrial action has had a massive impact on our ability to perform. So notwithstanding that, it's just, again, making sure we get the assurance that this board require. So a sense of that to think about. I don't know if you've got anything to say.
I'm more than happy to work through the framing of how we do that. I would say for the targets, particularly the ones that I referred to, there is an immense amount of assurance, oversight and drill down from ourselves, from NHS England, that we get involved in. It doesn't make the mitigations any less challenging, because they are challenging mitigations. And obviously, as I referred to, part of the rationale for having a national planning reset is to understand what can be delivered in the context of some of those challenges. So happy to work with Margaret, Catherine Evers in terms of whether the flow of assurance information is correct to the committees and whether the focus is correct. But there is a lot of assurance and work going on.
Thank you, Matthew. Any questions for any of those that have spoken? Rachel, please.
Rachel Shimon. Two things. I think in the documentation on this item, it's very useful to have a look at the national comparator figures, because it gives a really good sense of the nature of the issues facing us as a whole country, as well as Bob. So in terms of contextualising our performance, it's very useful to see that, as well as the South East information where we can. The other thing that I just wanted to mention was to thank colleagues in the ICB for work being done in conjunction with councils around special educational need and disability and improvement. This isn't an easy one for any of us, but we are determined to improve services for young people and their families, and we will only do that together. So thank you to colleagues here and not here today for that work. On the learning disability and autism page, which is page 77, I think, of our pack, there is a different way of counting some of the information linked to the waiting time for assessment. I wondered if it's possible for us to standardise that methodology of counting without it being too complicated for systems, because I think that will be helpful, because it's difficult to have a real comparison and to understand if there's something happening in another part of the geography that might help if we don't have the same way of counting. Thank you.
Margaret, do you want to take that?
No.
Well, I agree entirely regarding the need to benchmark, and I was going to flag at that point in relation to the uncertainty in the neonatal slides, where I think it would be really helpful to benchmark us against other systems in terms of the number of C-section deliveries as opposed to the number of overall live births. Thank you for your comments in relation to SEND. A lot of work going on, as you say, Rachel. It's a very challenging area, and I think your point about trying to standardise the data again is a really valid one, which I'm sure we can take forward.
Thank you, Nick. Margaret.
And thank you, Margaret Batty, Non-Exec Director. Just a broader question. It relates a bit back to the primary care conversation about private sector. So in terms of performance, I was just looking back. I've been reading a couple of reports come out recently about generational shifts among young people going online, preferring to go online, expecting to pay, having an immediate GP service and so on, and record numbers of people going online, going private for operations and diagnostics. And that's seen to increase given the delays and waiting lists and waiting times to see GPs and elective targets changing. So I just wondered if we're factoring in, or what we're thinking in terms of longer term performance with our population. You know, are we able to extrapolate and think, where is the balance going to lie in the next 5 to 10 years? What's that looking like in the Bob patch with our young people? Because we talk about being a healthy, wealthy area, very online, very connected. So it's just, I'm just starting to think that, is that something that's going to take the pressure off? What do we do about it? What do we think about it? Is it a conversation that's happening? Thanks.
You want to take that, Rachel?
So I just want to take one aspect of it. So I think what's really important is we have no oversight or data, for example, on private GPs, private general practice. We don't contract with them. We don't have oversight. They are independent businesses that are registered with the CQC. So it's really difficult to even know how much activity is going through that sector. I absolutely hear what you're saying in terms of there's a behavioural shift, there's a cultural shift in terms of what people are choosing to do. Sometimes that's generational, sometimes that is due to the situation we find ourselves in and the pressure that our services are under. So I think it would be quite difficult to even ascertain what is happening in some of those sectors. I don't know what Matthew's views are in terms of the independent sector with regard to surgery, but I think it's pretty difficult.
I think it is. I think it's an important point, and it's also difficult. And I think we have seen before, haven't we, that actually that use to the private sector, even the last time when we had extended waits and we reduced them, there was a shift. So I think we've got to have that narrative between how much is as a consequence of the operational performance we're placing now, and will that shift back once that starts to improve. I think the other risk around that, as sort of Rachel sort of alluded to, is if it's just part of the pathway, it can cause challenge and confusion in that bit of the pathway in terms of how we manage referrals. So I think it's a valid point, Margaret. I think let's take away the challenge of how we can start to factor that into our long-term planning, but it certainly isn't straightforward, and we don't have good data today. Doesn't mean to say we won't get it in the future.
Do you mind if we let me just bring George in for a final point, but I think we note that, and that interface between private and us is important. George.
Actually, just to come back on this, and perhaps something for the ICB to consider probably at primary care team level, is actually what we're seeing is increasing challenge around expectation. So Buckinghamshire Healthcare Trust did a really helpful thing recently, where they sent a clarifying letter to all GP practices to be made available to private providers around medication for ADHD, clarifying the relationship and essentially saying GPs won't be prescribing this if privately initiated on the basis of a lack of assured shared care processes. And then Buckinghamshire Healthcare Trust looked at their pathway and using clinical pharmacists to kind of rapidly integrate them into their services where they don't need that assessment, which will obviously help with the waiting list. I think this is proving to be really challenging, because what we're getting is people who are seeing private providers in the private sector and then coming back into the NHS with expectations that those demands of the private sector are met by the NHS and in a time period that jumps the queue essentially above those waiting. And I think actually what would be really helpful for the ICB to consider would be whether we can put some sort of framework about the expectations of that private and primary care interface to support primary care providers in essentially pushing back, because all this is doing is driving health inequalities. In this specific example, people who can afford to pay were getting medication for their ADHD quicker than those who couldn't. And actually what BHT have done fantastically well is set up a pathway and an infrastructure that means that there's better fairness across the board and clarity across all primary care providers about what's expected.
Thank you for that insight, George, and maybe we can take that away and check the other geographies against that. So let me quickly just turn to Saqib and Minu, and we'll close the conversation on this agenda item.
Thank you. I had a question on the workforce, and so I don't know whether anyone's able to answer on that. But the rolling turnover heading says October, but the table seems to be from June, the graph. But the question I had was, whilst it's been coming down from 14% to 11.5%, do we believe that will carry on the basis of the cost of living crisis and the cost control that we're going to have in the ICB? And do we know whether this includes intra NHS? Because if they're just going from one organisation to another, they'll obviously be within our turnover figure. But if they're not actually leaving the NHS, if anything, it's a good thing that we're working together as a system and potentially moving amongst ourselves.
I think we might need to come back to you, but that's really well pointed out. Thank you, Saqib. Nick?
Yeah,
Can we get to
I can't answer that with the level of detail you require, Saqib. So I think let's take that away and ask Caroline to look at the matter. I think the point you make there about turnover and whether leavers are actually moving to other NHS organisations is a really important one. I don't think we routinely monitor that. Clearly, we are trying to move towards having a single Bob workforce, and certainly I'm not unhappy if people decide to move between organisations within our system. What we want to do is retain them within our system. So I think trying to tease that out would be helpful. So again, let us pick that up with Caroline and see if we can bring you some data next time.
Thank you, Chair. This is simply an observation. It's actually a very thorough report. But when you look at it, it's heavy on performance, as it's expected to be, and process. And there's some quality, couple of measures towards the end about neonates and maternity. But as we mature, and this applies, I guess, to all ICBs, is if the primary purpose is population health and population health outcomes, at some point, we do need to have more metrics on outcome measures, because that will be a sort of a more mature system in terms of assessing performance, and process then will be at the back end, and the front end will be clinical outcomes for patients. So just a thought for future planning.
I'm just coming back on that. I think that's partly, and I think it will be a first step. So partly why we want to review it and give ourselves enough of a lead in time. So how do we reset it so it is more aligned to the system goals that we're discussing, more aligned to the joint forward plan, and presented in a way that allows interrogation. So I expect it's a start of a journey, nicking a phrase from Nick earlier, but that's partly why we want to try and do a reset next year to make the first step on that reset.
Thank you for that point, Minu. Yes, absolutely. Tori.
Welcome your question, and I think it's just noteworthy to say that we're starting to develop the capability where we can look at that risk stratification and segmentation across our 3 geographies. It's different in each at the moment, but the data sharing agreement we spoke about earlier will help get that single view, and then we can look into that. And we've also got some reports that we could potentially start to bring going forward, which would supplement the work that Matthew's doing, which we could start to feed in as it matures. And that's certainly something in the next 4 months or so that we could look at bringing in.
Thank you. Matthew Metcalf, CFO for Indeed. People will have read that as at the half-year point, we are £13.5 million off plan as an ICB. Taken at the system level, we are almost £35 million off plan, and that's with a a deficit plan in place. So our actual deficit as at half year was 59.1 million. People will see from that the enormous challenge we have in bringing the collective organisation, the system, back to a point where it can deliver its plan. As has already been alluded to at the beginning of this board meeting, there is a demand from NHSE to explain where we actually think we're going to be at the end of the year, with the assumption that we will deliver to the plan that we'd agreed with them in the early part of the year. That will be a subject which we'll be taking through further iterations with that intention in mind, but equally acknowledging the challenges that we face in really closing the gap that we presently have. The gap, as seen here in the report, highlights the £39 million gap between what we're forecasting as an ICB and our break-even position as an ICB organisation. The particular challenges are ones that we've experienced before in terms of continuing healthcare, prescribing, independent sector. What is perhaps a little bit different this time is how we're forecasting on the continuing healthcare position, which in run rate terms worsens through the course of the last, or is forecast to worsen through the latter part of the year, whereas prescribing is improving through the latter part of the year in terms of prospective overspend. There is considerable action being taken in both those particular areas, but in view of where we're at on continuing care, we've agreed we'll get an independent review, given the concentration, particularly in Oxford, of continuing healthcare overspends. If you take that then at the system level, I'm pleased that the SIP programme is beginning to show the benefits. What I know has been a huge amount of work in establishing proper plans, so we're slightly ahead at the year end, and sorry, at the half year, and the plans for the remainder of the year show that the amount of the SIP programme that falls into the high risk categories, which are the unidentified portions and those that fall into just opportunity rather than having any developed plans attached to them, has fallen now to around 22% of the total, with sort of progress each month through that period. So still £38 million to find within the plan, but good progress. I think if I'm to cast forward over the next half year, one of the challenges we're going to have is where we pay close attention to the non-recurrent delivery of savings. If you look at the first half, we have delivered about 50% of the savings that we have in that first half of the year recurrently, and clearly 50% non-recurrently, whereas our plan indicated 75% recurrently. And the implications, why we should pay attention to this is that will rebound on us next year. And I think the pressure on the system to hit plan will mean that the SIP savings, or the measures that we have to adopt in order to hit our overall plan, will swing that portion that we are saving non-recurrently to an even higher percentage. Really relates back to the point that Sir Keith was highlighting. So something that, as an indicator, we need to keep close attention to, but where we need to be gaining the assurance that plans are being put in place in order to ameliorate what could be a substantial non-recurrent pressure. The IECG, the ICS Efficiency and Collaboration Group, is a key forum for that. Yet IECG can't be the only vehicle through which all those benefits are taken. So, or at least sought, those goals sought. So that's all I'd say. Happy to take questions at this stage, noting the challenge and the work that's been undertaken over the course of the last 2 weeks, which we'll delve into more detail.
Thank you, Matthew. Thank you, everyone, for presenting. So I think this board notes the amount of risk financially in the plan. We can't get away from that. But what we seek assurance about are the mitigations that have been put in place by the providers, and your confidence in those to be able to deliver. Really, Matthew, is what we're asking for. And you know, I'm hoping that these papers give that sense to board members for us to be able to feel there is grip and control in the system in a way that feels as comfortable as it can be. Nick, I don't know if you want to comment on anything. So these are assurance papers really that we're asking you to consider.
To add what Matthew said.
All right. I think it's important to remember that Matthew's paper has been through the Systems and Productivity Committee extensively. So remembering that there are board subcommittees where all of these papers flow through, and we'll seek some assurance at the end of the meeting on their findings on that. But just to remind everyone that that's the case. So if there are no further comments or questions, I will move us on, if you don't mind. Thank you. So I'm going to, it's the Catherine show now, I believe. So you're going to talk to us about board assurance, please.
Thank you. So Catherine Mountford, the Director of Governance. So I'm presenting to you the Board Assurance Framework and Corporate Risk Register, and as always to highlight the continued improvement in process and reporting that's been undergone in the organisation. But I suppose, again, that step back about why does it come to the board? So it's not for discussing the register as the risk register in isolation, but to be assured as a board that we're using it as a key management tool and linking it to the focus that we have as an organisation, our agenda development, and as Rachel referred to early, are the goals that we're setting for next year going to address some of our risk areas. So if you look at it on that basis, a very quick overview, our strategic risks that are red are our financial and improvement of operational performance risks, which have run through the agenda. Rest of the strategic risks are mainly amber, but again, picking up on two of the main points that have come out, or two of the risks, the one on resilience and the one on transformation. Again, through our discussions today, we have talked about how we need to be delivering and improving today, but not losing sight of that improvement for the future. So doing that service transformation, making sure our system is more resilient, and shifting our resources. So on that basis, as a Director of Governance, I think it is underpinning what we're doing as a board and the way in which we're setting the agenda, or that we've probably got ways in which we can improve its presentation and reporting, but happy to take questions on sort of that basis. And then the other key thing I wanted to raise, and this did have audit and risk committee support, is given how busy we've been over the last 18 months, we have not had a board workshop discussion on risk and risk appetite and how do we want to take it. And my recommendation to audit committee and their support was we try and factor that into Q4 of this year, so January to March, but I know we're still quite pushed for time, so Q1 at the very latest. So that was my ask of the board, and happy to take any questions or comments.
Any questions or comments for Catherine? Is the board happy to commit to a risk appetite and risk assurance session so that we can ensure we're fulfilling our duty? I think we've got nods, Catherine, and no further questions. I think next up we have just a quick run through of the board assurance committees, the subcommittees that I talked about. Unfortunately, Aidan and Tim aren't here, but Saki, Margaret and I will pick up where we can. So if we just romp through those, we start with the audit and risk, please, Saki.
Yes, thank you. So on audit and risk, the only thing that I wanted to highlight was on continuing healthcare, we were going to decide where to do a deep dive, but Systems and Productivity have said that they want to hold a deep dive in CHC as well. So potentially that's where it'll be held. It's mentioned about the internal audit. On the IG, we've agreed that NEDs will not download to non-NHS laptops. There's no PO, no pay policy, which just basically means we'll have more robust controls if when our suppliers come to us for payment. And I think that's the only thing that I will add there. Obviously, in January, it's going to be a very busy period as the internal audit reports come in, external audit will begin, and it's just a busier time of the year because the plans for next year's budget cycle will be beginning as well. I think the normal December 24th Christmas Eve drop would have occurred. And finally, System NEDs meeting we're going to try and have in the new year for audit committees.
Excellent, thank you. The Place and System Development Committee is chaired by Aidan Rave, who's not here today, but just to assure colleagues that this is a system-based committee, and you can see that we've had continued representation from system partners in terms of the voluntary sector, and also a deep dive within Oxfordshire Place. So we continue to learn from those geographies and make sure that that's being shared across our 3 geographies. And we had the Chief Operating Officer of Health Innovation Oxford and Thames Valley attend to give an update. So again, keeping an eye on the wider stakeholders, and we'll continue to improve this committee as the board continues to refine its focus as well. So thank you. Population health and experience, Margaret, please.
Thank you, Sim. Very briefly, Margaret Matty, non-exec NED. We've already, the main topic I was going to talk about was SEND, so special education needs and disability. I think we've given that quite a lot of airtime, but I think the point for the committee was that SEND and the challenges and the opportunities and the pressures encapsulates system working. It encapsulates virtually everything that we do. So it was a really interesting conversation at committee that just that kind of light bulb moment that this is about working with local authorities. This is about bringing our services together. This is about voice and patient, family, carers involvement. So all of our emerging agendas are really, you know, they're shining through in SEND with immense challenges. So we've already talked about it, but it's really on our agenda and in our sites at the moment.
Thank you, Margaret. And then Saki, you're going to help us with system productivity, please. Oh, sorry.
Could I just make a very technical correction on that? Apologies, I haven't got a chance to raise it before. There's reference to 90%, 92% compliance on its winter plan. That's actually 92% compliance against the strategic control centre assessment.
Right, page, please.
This is in the population health 143. First paragraph under assure urgent emergency care and winter plan. Just to note, that's a 92% compliance against the strategic control centre assessment, not against our full winter plan.
Thank you for that correction and accuracy. Thank you, Matthew. Okay. Matthew.
Yeah, most of what I was going to mention, the other Matthew has already covered, but the only thing I was going to mention, as you had stated, these things do come through the committee before they come to here. And we also had a deep dive on procurement and medicines management, which was very insightful. And I think the final thing on ICG, whilst it's really important in the work that we're doing within NHS partners, I think the next phase, especially again, we don't want to harp on about the challenges we'll have next year, but I think we need to extend to non-NHS partnerships as well, both charity sector, but also council partners as well. So whether it's on procurement or whether it's, for example, on where we hold our meetings like we are today. Thank you.
Noted. Thank you. Thank you, everyone, for that. Let's move forward, please, to the board forward plan. I think, Catherine, you're going to just talk us through that.
Yes, so again, quickly, this comes for information to give that overview of what's on the plan going forward. Picking up from today's agenda, we've got the planning and NHS impact to add to January's then agenda, estates to March, and digital and data update is already pre-programmed in for May for the 6 monthly update. So again, identify through me any areas for the forward plan so we can look at it. And as Sim said at the beginning, we keep the structure of the agenda under review. So it's the forward plan has been restructured to match the current structure of the agenda, but will amend as anything else amends.
Thank you, Catherine. I think it's just important. We're a learning organisation. We have to be, because we're looking and seeking change and working in completely different ways. Therefore, you know, we have to continue to learn and share that learning. So in that regard, I welcome any emails with thoughts about the agenda and how we run, and any further improvements we could make so that it becomes ever more efficient. So I only have to say, is there any other business at all that anybody else would like to bring up at this stage before we close this meeting? Silence. Thank you very much for your contributions, your thought. Can I thank all the NHS colleagues, all colleagues within our patch for their hard work, commitment and continued loyalty, and the continued collaboration that Victoria picked up as our newest sort of member. Thank you all.